I'll be more social in future, ma'am. Promise.
I don't see Anita. Anita is also supposed to come, na?
Yes,
Anita call.
Just Vanna make a call to Dr. Anita.
Social in future, ma'am. I'll be more social in future, ma'am.
Shravanti, we are ready.
Yes, sir. So,
Mandakini to
Sadhana ma'am, should we start?
If you are waiting for somebody, it's okay. Just wait for a few minutes. You are waiting for somebody.
Sure.
Always in time.
Just decline the call. Probably she's busy somewhere.
Okay, fine. It's
Let's
okay.
start. Let's start.
We have two experts. It's okay, fine.
Yeah.
So, respected doctors and dignitaries, very good evening to all our honorable guests who are a part of this live scientific webinar today. Thank you to each and every one of you for squeezing time from your busy schedule. Myself, Shravanti Mukherjee, Group Product Manager of Corona Remedies Private Limited. We are the makers of Core9, Treasure Import and Stimuport. We welcome you all for today's webinar by Nigf.
Dr. Tanudeep Kaur, please mute. Dr. Tanudeep Kaur, please mute. Host can please mute her.
Please mute everybody. Shavasti, mute everybody except
Actually, the host is Vasu.
Oh God. Hello. Go on. Shavasti, go on.
Ma'am. So we welcome all of you for today's webinar by NIGF Academia Series Obstetrics on the topic First Trimester Fetal and Aneuploidy Screening, Methodology Challenges and Solutions. So this session will be followed by panel discussion on the topic of solving enigma of ultrasound soft markers. And our sincere thanks to all our experts, Dr. Sadhana Gupta, speakers, and program panelists for being part of this meaningful interaction today.
The host is not a chairman.
And also thank Dr. Ritu Srivatsav and Dr. Vandana Gupta for being the coordinators and the hosts for this initiative. Now I invite Dr. Ritu and Dr. Vandana to set the premise for our scientific interaction today. Welcome, ma'am.
Good evening, all the faculty and all the dear delegates. We are starting a very, very, very interesting webinar on fetal diagnosis of fetal abnormalities. So the first, I'll just like to share my slide. So, is it visible? No?
It is visible, ma'am.
It's visible?
But
Okay.
the text is not visible.
No, I am visible, but my text should be, my slides are visible or not?
No, ma'am.
No. Okay, I'll stop share and then come again.
Ma'am, she's displaying it, Shravanti.
No, I've got it. Shravanti, you have done or it's me who's done it?
I think Shravanti is done, ma'am.
Ma'am, it is live. So it is live now.
It's live, no? So I'm making it full screen. It's okay now?
Yes.
Yes.
So we are starting our NIGF Academia series, and our program directors are respected Dr. Sharda Jain ma'am, Dr. Sadhana Gupta, Dr. Ragini Agarwal, and Dr. Sangeeta Gupta. Dr. Sharda Jain, well known to everybody who has mentored and started this NIGF as a whole, and she has been a mentor to many of the students and colleagues, and she has given so many concepts of Janani Suraksha Yojana and Asha workers to Government of India, and she is spearheading a movement on doctors' safety and zero tolerance against violence. And she has been decorated with many lifetime achievement and living legend awards from many bodies. And definitely she will be awarded more and more in upcoming time. Dr. Sadhana Gupta, another decorated person, and she has also been a recipient of Dr. N.A. and Shailja Pandit Award for Women Empowerment, honored at national and international forum for exemplary work done to reduce maternal mortality, community services, and women empowerment. And she has been an awardee of chancellors and Dr. Naval Kishore Gold Medal for Best MBBS and postgraduate as a postgraduate student. There are so many other accolades to her.
Go
So
ahead.
I'll just move on. Yeah. So another Dr. Ragini Agarwal, another decorated person who has received so many awards like APJ Abdul Kalam Award for Academic Excellence, Lioness Club Award for Corona Warrior, IMA International President Award in 2021, and Best Committee Chairperson in 2022 for IMS. Another esteemed person is Dr. Sangeeta Gupta, who is ex-HOD at ESI, Postgraduate Institute of Medical Sciences. And she has received many, many awards, and her field of interest is eliminating preventable maternal mortality, for which she has given orations many times in Delhi. She has been recognized teacher and has many publications in international and national journals of repute. So we are now starting with the inauguration and blessings from very two senior personalities, Dr. Meera and Dr. Madhu Nagpal. So she'll be introduced by none other than Dr. Sadhna Gupta.
Thank you, Vanna. First of all, as a resident NIGF and an organizer of this program, I welcome each and everyone, and with a hearty thanks to all esteemed faculty for being together in all the NIGF Academia series. So we are really blessed to have none other than Dr. Meera Agnihotri and Dr. Madhu Nagpal to bless us in the NIGF Academia series. So Dr. Meera Agnihotri is a mentor figure as a teacher, philosopher, guide to generation of students, and her contribution to teaching and services for women have been recognized by numerous awards and honors. Important thing is, at this point of time, she is the chairman of the UP State Ethical Committee. She is advisor to government of India on women health, and she is the president of WWW Women Foundation, Women Foundation, and this foundation is really active. She has organized international conference when the president, Honorable Mr. Kovind, was there to inaugurate. So we always look forward to Dr. Meera Agnihotri for everything, and she has been organizing chair of many conferences, like since I think we can say 2 decades, and she is a persona beyond awards. So we are really privileged to have Dr. Meera Agnihotri. Or Madam, we like to have your words for this webinar and for the North India Gynae Forum. So thank you very much, Dr. Meera Agnihotri. Kindly stop share so we can have the Dr. Meera Agnihotri's words.
Okay.
Can you hear me?
Yes, ma'am. Yes, ma'am, we can hear you.
I'm very happy that Sadhna has taken out some photographs which are right now so very impressive and new to me, which I have not seen for such a long time. At the outset, I extend my heartfelt gratitude to the organizing team and the program directors, Sharda ji, Ragini, and Sangeeta and Sadhna in particular. I tell you that NIGF formation itself speaks volumes about the integrity of 7 states which are united and are bent upon creating a new horizon in the sky of the Foxy. You see, many of us were not able to participate in many places, and we have got personas, personalities beyond imagination. They can present like anything. And I personally feel that NIGF will be providing a wonderful platform to real workers who can show their worth at the national and international level. Sadhna, I can tell you that I am attached to her for decades, and I saw her working as a grassroots worker to the most important person who can just be a hero of whole of the academics. She has got capacity to make weeping people smiling, angry people looking down and forgotten that they are angry with sadhana. And even if somebody is angry with sadhana, I can tell you, he cannot afford to continue this thing and they have to lose. And that is what a person who is being required for a federation like Obstetrics and Gynecological Societies of India. She has worked as a committee chairperson, and I remember the number of the awards which she has had at that time when she has completed her tenure as a committee chairperson, because I was one of the important persons sitting over there for clapping, but I don't know how long I kept on clapping. So Sadhana, I extend my heartfelt good wishes to you for, first of all, being president of such an important organization which is in the infancy of its this thing, and being president, taking the reins of this important NIGF. I tell you that it will be the first step of climbing. And I know and I'm confident that the tenure which you are going to have with the good wishes of all of us present over there, you will prove to be one of the most important, memorable, highest chair owner of this federation. Sadhana is a great academician. She is a voracious reader. As a teacher, I can say that her presentations are always excellent. And whenever she presents, I don't find a point to put on telling that you have missed this thing, except that she is doing very good. So with these words, I extend my heartfelt love, blessings and everything to would-be president of highest association, which has started as president of NIGF, which may be the first step in her presidential tenure. And I believe the present Dr. Madhu Nagpal, with whom I am sharing the dais, I am really honored to be present with Madhu, her smiling faces, and you see her presence by my side itself just glorifies me, and I feel honored that yes, I am with her. So Madhu, I believe you will be agreeing with me that our choice is very correct, and I just request everybody present over here to just reciprocate and multiply your request so that we can find a person who has got capacity to be at the highest chair and must be able to command the association, not only with academics, but very many other qualities. Thank you very much, Sadhana. I'm very happy to be a part of this academic meeting, and I really want to be a part of it till it ends, but I may not be able to continue because in our medical college, an inspection is going on, and I am supposed to be, I'll be here for some time. So once again, it is with folded hand with the God, I'll be praying for your UC welfare, and I want to see you at the highest chair. It is my internal desire, because I saw you working, you're passionate working, and she has got passion to जिद पकड़ लेती है कि मुझे ये करना है तो करना है, and that is what is needed for a person who has to do it. I believe Madhu, Deepika, everybody will be agreeing with me that my words are not. So it speaks volumes about her personalities, that you have witnessed them and you have heard them, and you have saw that how she conducts the panel discussion and commands the everybody present over there as if she's master of whole of the subject. I also keep listening because very many things I also share with her. Thank you, Sadhana. Thank you very much.
Thank you, Madam. NIGF is blessed, and I am blessed for your appreciation, because that true teacher, what really matters, and blessings of elders goes a long way. So we will like to prove to your expectation and maybe beyond expectation. Thank you very much for your precious presence, despite your very, very busy schedule. So it is we are privileged to have Dr. Madhu Nagpal, another teacher which we have been associated with such a long time in so many conferences and academic sessions. Vanna, please display the CV.
Here it is. Here it is.
Madam is ex-professor, head of the department, Government Medical College, Amritsar, and SGRD IMS Amritsar. She has been graduated in 1972 from GMC Amritsar with best graduate of the student, post-graduation in June 1981. She had approximately 42 years of academic teaching experience, and she is passionate about teaching contraception, practical, obstetrical, published over 105 papers, and has been ex-president of the Society and the editorial board of 2 journal and peer review of Journal of Repute. We are privileged to have Dr. Madhu Nagpal with us, and we request Dr. Madhu Nagpal to bless NIGF and bless the webinar for with her words of wisdom.
Thank you, Dr. Sadhana. I hope I am audible. Is it so?
Yes, yes.
Yes,
Ma'am, you can
good.
increase the volume a bit.
Yes, I have increased. Thank you so much for inviting me. You know, when you invited, I thought blessings, then it means I'm a first generation doctor. And now I feel 4th generation also has come. Anyway, you have brought a forum which is making the first generation and 4th generation meet together on this forum. So lot many stalwarts. I can take the name of everyone who's there. I've seen them, you know, all through these years. And today, you know, they are going to share their thoughts with the youngsters. So Dr. Sadhana, NGF is your brainchild. Look, and it is growing so well. You must be very happy how it is growing. But for you, I have special words, because I do not know how you do the time management. How much energy potential do you have? When do you write a lecture? When do you give a lecture? When do you travel? When do you organize? How you contact everyone personally? How you make and plan something for a meeting? And how you see you got it executed to the perfect extent. So nice of you. I'm really a big fan for this reason. And I really want to see how you balance things and do it so well. You're graceful, very graceful, and you're very, very soft in talking. I admire you. I'm so thankful you called us to Gorakhpur, and I happened to see Ayodhya. Never would have come the chance if you not called me to Gorakhpur. So nice of you, Dr. Sadhana, for having. I really wish you. You are a fighter. We really want you to be president of OXY, and I will not mince the words. Enough the effort you are doing. Probably you united the whole North, and we will definitely follow you. You will not get a chance not to have it. So we wish you this election year a great success. Now you got all the personalities who are the achievers. I find Dr. Sharda absolutely a bindas lady. And she's, you know, at the back of this forum. So 2 of you are going to make a lot of heights. Rest, Dr. Deepika, I know everybody knows. The subject is so good. The forum is so good. The ladies who are cheering are so beautiful and charismatic. That's what I can say, that these are my blessings. But then I look at me, I'm not first generation. I'm amongst you and young enough to learn things. You know, I really want to know what is happening today. So I'm like a child and a student, and I want to listen to everybody and learn. Thank you so much for inviting me. God bless you. May you get your success. We really pray for your health and your success. Thank you. Best of luck.
Dr. Sadhana, unmute yourself.
Thank you, madam, for your precious blessing, precious presence. And it is really an honor to have senior persons like Dr. Meera Agnihotri and Dr. Madhu Nagpal among us, because it keeps us motivated. Thank you very much with this inaugural function, and with the, we are blessed to have your blessings. And Dr. Vanna, you go ahead with the first session. Dr. Mandakini has joined, and all the 3 experts are with us.
Sadhana, please make a correction.
Yes, madam.
Instead of Prerna Agarwal, you have written Deepti Agarwal.
No, Dr. Deepika Deka Prerna. It is correct, madam.
Ma'am, it's okay. The session 1 is note address. Now we are going on towards our webinar, which is very, very interesting. And the first topic is a very, very relevant topic to today's clinician. First trimester fetal aneuploidy screening, a methodology, challenges, and solutions. The speaker is none other than expert Dr. Mandakini Pradhan, and we have experts in Dr. Deepika Deka, Dr. Prerna Agrawal, and Dr. Anita Kaul. Dr. Deepika Deka, she is a senior consultant of fetal medicine and genetics, and she is a she was a professor and unit head OBGYN at AIMS. She has been a vice chancellor at SS University of Government of Assam, and she has been a director AIMS Kalyani, has been a past president of SFM and past chairman of Genetic and Fetal Medicine Committee, FOXY, AOGT, and ISOPAR. Dr. Prerna Agrawal, another luminary over here. She's from Dr. MC Agarwal Hospital and Dr. Prerna IVF Center. She's president for Firozabad Obs and Gynae Society, and she has received North Zone Yuva Foxy Award and participated as faculty in various national and state level conferences. Dr. Anita Kaul, another decorated person. She is currently head of Apollo Center of Fetal Medicine at Indraprasth Apollo Hospitals, and she has been trained in fetal medicine with Professor Kypros Nikolaidis, and all of us know she is excellent person in her work. She's a national examiner for Fetal Medicine Foundation UK in India, and has introduced a much sought after fellowship program in fetal medicine. She's president of FMF India, which aims to train doctors in smaller towns, enhancing skills in OBS ultrasound, and collaborated with FOXY to run successfully FOXY FMFI online ultrasound certification program. She is also vice chairman of RCOG North Zone and actively involved in many academic activities. Dr. Mandakini Pradhan, our chief, ma'am, I would request Dr. Deepika Deka kindly to introduce our speaker. Dr. Mandakini, ma'am.
It's a real pleasure to introduce Dr. Mandakini Pradhan, who I know for the last 35 years, I think, as a young student, and now as the chief of the genetics department in the SGPGI. She's the heading the department, and her aim is to establish maternal fetal medicine in India. She's chairperson of the Genetic and Fetal Medicine Committee of FOXY. And as I said, she's professor and a head of the SGPGI Lucknow, where she's running fellowship programs in maternal fetal medicine. She has several publications and books, chapters and books. And I know how much pains she has taken to develop the department. And I have been fortunate to be involved with that process for several years. And Dr. Mandakini, I'm sure you're going to really throw light on the topic of the first trimester screening, and please start your session.
Thank you, madam, for those kind words. And my regards to all these seniors who are present there. Thank you, Dr. Sadhana, for giving me this talk. I was, how do I share my screen? So
look at share screen below.
Yeah, okay.
Yeah, and open your slides.
Yeah, so that's share. Open.
The green share screen.
Allow Zoom to share.
Put it on and open your slides.
Yeah, I have already opened it, but it says that calendar, camera, accessibility.
Travasti, please help her. You open the presentation is open now in your below. Then you share the screen. Just share.
Go to the first slide.
Yeah, I have gone to the first slide.
We can't see, ma'am.
No, we can't see.
I
think Mandakini, just stop sharing and then start again.
Okay.
Stop sharing.
Yeah. Yes. Zoom.
Can you just go to the share screen button, which is in the bottom?
Yeah. Yes, I have gone there.
Okay.
And it says that whiteboard and universal access something, and it has a basic, it has an advanced.
Ma'am,
you should click on the main icon. You are clicking on the right side button. So you should click on the share screen main button.
Yeah, I have keen in that red, the green.
Correct. That is the one, green one. Share screen.
Is that it is share. Allow Zoom to share your screen.
Correct. You should say okay, right?
open.
Allow.
Correct.
Yeah,
Allow,
allow.
ma'am.
Yeah. Then it says that security and privacy.
No, ma'am.
No, Mandakini. Let me tell you, Mandakini, to start share screen.
Yeah. Share.
Yeah, go to your slides. Are your slides on the desktop?
Yeah. Yes, it's
Just
open.
go to your slides.
And click it open.
Yeah.
Go to your slides.
Yes, I have
Wait.
opened it. Yeah.
Just open the first slide.
Yeah, I have opened the first slide.
Hasn't it come?
No. Ma'am, on her
Actually,
screen,
Dr. Mandakini, hospital security, so it is not issue, so SDPGI security issue. I think you must be doing.
No,
Always.
this thing always.
Mandakini ma'am, now can you just try to open the share screen button? You click on this share screen button now, right now.
Yeah, I am doing that.
Once
Zoom.
you open the presentation and keep it aside, and then now you can share the screen.
Yes,
Or you can send it to Shavasti, your mail
Yeah.
ID. You can send it to so that she can share from your side.
Zoom.
Security, I think there is some security issue with this.
No, it's probably because of.
privacy, you will have to share your email ID.
No,
Your email ID we don't have.
No, it is not asking me. It is asking me. Asking me that basics, that is whiteboard, and then advanced. It is something which is and files. So I'm going on.
I know,
Ma'am,
don't
to
go
the
there.
files.
Don't
Ma'am,
go
to the
there.
files.
Go to your slides.
Yeah.
Don't look at all that. Go to your slides straight away.
I am going slide. Yeah.
Where is your slide share?
There is.
Where is your slide?
And that's on the
Is
desktop.
it on desktop? Yeah, open it there. Go directly.
System directly. It's open only.
Yeah, then
It's not sharing, ma'am.
It is not being
then
shared, ma'am.
start sharing.
It's
On the right side, there is a thing called slide share. Again.
it's Mac, and then Mac is asking for Microsoft SharePoint.
No, ma'am. I also did it from my Mac only.
Yeah.
Just have to click open the share screen, and
Open.
then click on the bottom. Your slides would be there. On the bottom, there are so many icons. The slides would be there. Click open on that.
Yeah. On the button, I have got.
Where are your slides? On the bottom, there would be
Yeah, slides are there.
slides.
I
Are
have
there. You
seen
click
the
open the slide, ma'am.
Yeah. And then share.
Then share. Yeah.
Share. This share will not go to OneDrive personal. No. Yes, share to something different.
Ma'am, या तो WhatsApp
Ma'am,
कर
can you
सकते
share
हैं.
your PPT on WhatsApp?
Yeah, share the PPT on WhatsApp. We can do it.
And you start with your talk because you can, I think you can start the talk while we share the screen.
Yeah, you send the, you send.
You start speaking also. No? You have this thing and please
Yeah.
share on WhatsApp also the presentation.
Presentation, and then anybody can.
Then we can share for you, ma'am.
We will share for you.
Can I send it through mail?
Yeah, you
And
send. So for whose mail are you sending it to?
Yeah, just tell me whose mail.
Shavasti, you give the mail. On the group, you give your mail ID.
Sure, ma'am.
And you can start also your talk. No? I think you can start also. No? Dr. Deepika, Dr. Anita, we can have your talk. No? You can start with your talk.
Whose email address? Can someone tell me the email address?
Shavasti, tell me.
SHRAVANTHI SHRAVANTHI DANTHI V for Vellore, A for Apollo,
Shravanti.
Shravanti M for Mangalore, Shravanti M.
Just a minute. This thing that you had sent. Yeah.
@coroneremedies.com. Yes, ma'am. I have shared you my one link from my mail ID, the same mail ID.
In chat, right on the chat.
Yeah. Okay. What I'm doing is yeah, I have sent you.
Okay, let me check.
Just a minute.
And you can start talk also, no? Your talk.
Sorry, I'm really yeah. Send. I've sent it. And if you can please do that. Okay.
We recognize presence of Dr. Achla Batra, Dr. Mala Srivastav among our audience. So, Mandakini, I think you please start talking. Yes, you so by the time she starts. Yes.
So, yeah, I'm by the time you will this thing. Sorry, really sorry. And then I will be quick in doing few slides at least so that I can make it up. So we know that all of us see pregnant patient, and then all of us screen for many diseases. And we should not forget at the outset, I must say that as a practitioner, we should not forget about anemia, diabetes, preeclampsia, preterm. And then specifically from my side, and Madam Dr. Deepika Deka also will agree with it, that we should not forget doing a RH blood grouping of the women, because we do see patients coming with double marker test without having a blood group. And whereas the patient ended up having a RH isoimmunized pregnancy. So to diagnose this fetal, the fetal condition, at the end of the day, we want a healthy mother and a healthy baby. And to have all these maternal condition needs to be looked into. And what we need to know is we do screen for few conditions. And one of the condition is fetal aneuploidy. And aneuploidy, what is aneuploidy? As a gynecologist, we sometimes get lost. It is euploidy is when 23 plus 23 makes 46 chromosome. 23 from each gametes makes it euploidy. If there is one extra, then that is called as aneuploidy. Or there is one missing, it is also called as aneuploidy. So trisomy 21, 18, and 13 are example of aneuploidy. That means we have got one extra chromosome, 21, 18, or 13. And that is called as a trisomy 21. In other words, it is known as Down syndrome. And all of us in day in and day out.
Just received the mail. Abhi mila hai. Abhi mila hai.
Okay. कोई बात नहीं, आप open कर देंगे तो फिर I will close from this side and then go on to that.
Carry on.
Yeah. So the initial this thing are somehow introduction, so I can go on. So if one of the chromosome is missing and that happens to be a sex chromosome, then that is, yeah, great. Thank you so much. So you go on to slide number 7 directly. Don't, skip all these. Yeah. Then next. Yeah. So if one of them is missing, then that is called as a Turner syndrome. Can I have next? So in a place where there are 250 deliveries, and, one of them, that is 0.4% of all live births, fetal deaths, and pregnancy termination will have a chromosomal abnormality, and almost 50% of them are because of trisomy 21. Why I have made this slide is, if a product of conception or any pregnancy termination for any other reason, if we are doing a chromosome trisomy 21 testing, then we are looking for only 50% of the cause, not the whole thing. So please be careful when you are ordering. Do not order a QF-PCR for trisomy 21 alone. Even if you are ordering for 18 and 13, you are covering, say, 70% of them. You are not covering 100% of them. So it is other chromosomal abnormality also includes in those fetal deaths and pregnancy termination. Next slide, please. So, I had a lot of animation, so this will be. Anyway, the screening methodology for aneuploidy, we know that maternal age, then serum screening, ultrasound, these are now every day-to-day function. But what we need to know. Next. So what is there is, we know that maternal age is like earlier days, we were happy in getting 30% mark. Our grandfather, great-grandfather, they used to pass the examination and have 30% mark. But not these days. Always we want more than 90%. For our children, we will also want more than 90%. Similarly, for a screening test, if we are doing only maternal age, then we are picking up 30%. Not a very good test, not at all. So next slide, please. So what we have done is we have, since long, we have combined the maternal test with serum screening. Second trimester are triple test and quadruple test. There is a big no of triple test. So please forget about it and please do not order. Once in a while, I do get patients being referred following a triple test. Those who are doing, please forget it and then go on doing quadruple test. So what is done in first trimester is a double marker test. Next slide, please. So maternal age along with a blood test or a double marker test that is done in first trimester gives us a sensitivity of around 60 to 70%. We still are not very happy with 60 to 70% landmark. So we want to move further, and moving further means we add one more marker, and that is nuchal translucency. That is the middle bar, which shows that 85 to 95%, say roughly around 90% sensitive. So we detect by adding another marker, which is an ultrasound marker, we achieve a sensitivity of 90%, and whereby we are more than happy. Next. So we need to know what is that ultrasound marker, and it is none other than that is nuchal translucency. But nuchal, we should not be blindly doing a nuchal translucency. Dr. Anita and Madam will agree with me that it has to be standardized. So CRL between a specific CRL, that is 45 to 84. If you are unable to remember the 45 to 85, 11 to 14 weeks. Though technically it is 13 plus 6 weeks, but for remembering, I have written that 11 to 14 weeks. The plane has to be sagittal plane, mid position, high magnification, proper caliber placement, 3 measurements, highest needs to be taken. All these needs to be taken care of. Next. I will not go into how to take it and what all, but there are other ultrasound marker that today I concentrated on. How do we, all these confusion is being created with all these reports. So there are other markers like nasal bone, ductus, where A-wave reversal is an indicator, and tricuspid regurgitation. I knowingly have not concentrated on all these extra marker. Next. Let's know our basics. So what we do is we do an ultrasound first, determine what is the gestational age, do a nuchal translucency, and then send the patient for with all these information, send the patient for a double marker test. So this ultrasound finding is combined with a serum test, and a final report comes out of it. So what are the other correction factors that are to be entered is number of fetuses, whether it's a IVF pregnancy, maternal age, weight, ethnicity, smoking, diabetes, and previous history of trisomy 21. Next slide, please. So the ultrasound data has to be correct. And here is an example where nuchal translucency is 2.76. But if you see closely, the CRL or crown rump length is 41 millimeter. Should we go ahead and do a serum marker? Probably not. Everyone will agree that it should be between 45 to 85. The extremes of it gives you not that good accuracy. So if it is less than 45, then it will not give you that accuracy. So nuchal translucency and nasal bone needs to be reported in this serum marker testing. Next. So next, you please press it. So here is a report, the same report which says that ultrasound, risk of trisomy 21 is more than 1 in 50. But see the CRL, it is 41 millimeter, and the gestational age itself written as 10 weeks, 5 days. So how do I take this report? And this is nothing but we should not do it. We refrain from doing it. And please let us remember that it should be CRL should be more than 45 and gestational age should be more than 11. Nothing less than that. Next slide, please. So, and that will give us, next, please press this. This yellow, don't see all those yellow because that is second trimester. Knowingly, I have done it yellow. And now maternal age, we have striked it off, which gives us 30% sensitivity. Then we have got double marker and we have got double marker plus NT. What we learned is if we are combining NT, then our sensitivity is increased to almost 90% with a 5% false positive rate. So definitely you will be happy with a 90% mark if your you yourself score or your children score. So be happy with this maternal S, double marker and NT, which is a combination of three things. And if we are unable to do an NT, then if you are doing a double marker only, that is only serum marker, then you are limiting yourself to a sensitivity of 60%. Next slide, please. So what I have taken out is this, that is the reference that I had taken out. So here is a case where first trimester screen was done, which shows that low risk. And if you see closely, this is a patient who attended us in July 2022. So 14th July 2022, this thing was done. She attended us in August. Why? So this screen was low risk. Next. So what happened? She was advised another test, that is quadruple test in second trimester, and it is high risk. So definitely there is a lot of confusion between these two. Next slide, please. So first trimester followed by second trimester. This is the dilemma. So if first trimester is giving a low risk and then high risk, or vice versa, high risk and low risk, how do we integrate? What do we do with that? And patient is confused, more confused, probably the doctor who is prescribing. And if they are referring to one of us, then we are like, it's difficult to counsel the patient. So can we integrate both of them? What to do next? Next slide, please. So first and second trimester screening should not be performed as independent tests. They can be combined, but they should not be independent because false positive rate will be unacceptably high. And if the results are disparate, then counseling is problematic. As that was done in this patient, it was very, very confusing. How do you counsel the patient? First report low risk, second report high risk. Next slide, please. So, what is being done is to integrate both these tests. So it is called as an integrated screening. So what is integrated screening is first trimester is done, the report is kept in the lab itself, not disclosed. And second trimester screening is done, both the reports are combined together, and at the end, the final report is given. Just press it. Yeah. So what is, no, previous, please. So that is called as an integrated screening, and that is after all the tests are done, a report is then generated with a T21 sensitivity of 94%. Good, but any patient will accept that I have done a test, the lab is not giving me report. The patient will wash your brain. So if you are doing NT along with NT and serum marker, then the sensitivity is coming as 94%. If you are doing only serum marker and then quadruple test, double marker followed by quadruple test and integrating both of them, then that is 88%. None of us are doing it. None of the lab are doing in India. And I'm not aware if madam is able to do it. Dr. Deepika Deka madam probably may highlight it, and Dr. Anita Kaul may highlight it. At least we are unable to do it. Next slide. So integrated screening. Next comes is sequential screening, where we do step after step, and first trimester screen we have done. If the patient is high risk, we send them for invasive testing. Those rest all, intermediate risk, high, low risk, are subjected for second trimester screening. So here we are doing two tests, that is first trimester, and then with the first trimester report as a priori risk, we are doing a second trimester screening. That is almost none of the lab are doing. So what is contingent sequential is first trimester you are doing, high risk are subjecting for invasive testing, low risk are no testing, and there is something called as an intermediate risk where we are doing a further follow-up or further testing in the form of maybe invasive testing, maybe a NIPT. So most of them are preferred as NIPT. So what is being followed is a contingent sequential testing or contingent testing, and I have renamed it as intelligent testing. Next. So we do not remember stepwise sequential, please, previous slide. So it is intelligent testing. Intelligently, we are ruling out high risk invasive testing, low risk, no testing, and intermediate risk further testing. So next slide, please. So, if we are doing a sequential contingent screening, we are getting a sensitivity of 91%. Next slide. So these are not being done. So we are left with this test. And as SEOG has recommended, it should be available. The screening should be available to all. It is the woman who decides. And if she doesn't decide for any further testing or any screening test, then that's at least that's her wish. But we as an obstetrician must advise them for this test. Next slide, please. And we may screen next and rule out many, prevent birth of all these Down syndrome baby. But what additional information these serum markers give is, if PAPE is low or beta CG is low in first trimester, then it may indicate that their baby can be small for gestational age. There can have fetal death before 24 weeks or after 24 weeks, depending on the PAPE or beta CG, whatever is low. Next slides, please skip 3-4 slides. Yeah. Similarly, second trimester marker, and this PAPE and beta CG low and low may indicate you to monitor the pregnancy in a close, like frequent monitoring for fetal activity in late second and third trimester, so that you can pick it IUGR, and then accordingly you can act. Next slide, please. So this next, go on to next slide. So what then comes is, what is there in first trimester is cell-free fetal DNA or screening for fetal aneuploidy. All of us by this time know that fetal DNA circulates in maternal plasma just like tumor DNA. They were found in the person who is carrying that tumor. So placenta acts as a tumor, and this trophoblastic DNA circulates in maternal plasma. And if this plasma is DNA is separated, we have got maternal DNA plus fetal DNA, which are colored as green. If we have two green, then it is normal. If it is little excess or it is 50% of it is increased, then it is abnormal. This is the basis of doing a cell-free fetal DNA, or what is called as a NIPS or NIPT testing. Okay, next. So there are advantages. It's non-invasive testing. Sensitivity is very high. For trisomy 21, it is almost 99%. And for trisomy 13 also 91%. Specificity is good. It can be done after 10 weeks. Best is 12 weeks. And report is available maximum by 2 weeks. These days they are giving it 7 to 10 days interval. Disadvantages next. Disadvantages are, it is not a diagnostic test, doesn't tell you about other chromosomal, like just now I tell you about, it may indicate that fetal IUGR and early fetal death. Not suitable for multiple pregnancy, though few labs have started doing it for twins. Cost is little higher. The cost has come down over the time, but it is little higher than as compared to the serum screening. May not reflect the fetal karyotype. Availability in periphery, it is difficult to be, little difficult. Pregnancy with cancer, we get to see patients with a different type of cancer, specifically breast cancer with pregnancy, where we need to remember that we cannot do NIPT because cancer tumor cells also may interfere with the result. Next slide, please. So, okay. So, lot of animation I had put. Sorry for that. So what has happened is, this is 2 screening tests done on the same day. So please give little one thought about this, that those who are listening to this lecture, please think about, the patient is asked, this is the same patient from the same lab on the same day, that is 7th of July 2022. First trimester screening, and that is double marker screening on the left hand side. And the next generation prenatal screening test or NIPT on the right hand side. So should I go ahead and do such type of practice? Next slide, please. So we need to rethink, and whom to test. If I'm clear whom to test this cell-free fetal DNA, probably I will not do serum screening, double marker. Then again, I will same time I will say, no, I have ordered for this. Again, I will order for cell-free fetal DNA. Another screening test. So what are the indications that are maternal age more than 35? Those intermediate risk or intelligent sequential testing that I talked about, that not exactly intelligent, but contingent sequential. So that category where there is intermediate risk group, we can go ahead and do an IPT. personal and family history of prior pregnancy with trisomy 21. In my experience, many of the couple, they opt for directly invasive testing. And parents with translocation involving trisomy, involving chromosome 21. So next slide, please. So these are indication of doing it. Which method to be done? You will be bombarded with different types of methods that the labs are doing. There are 3 types of method. One is massive parallel sequencing, one is chromosome selective sequencing, one is single nucleotide polymorphism. Most of the lab these days have come on to massive parallel sequencing, which is a good test, and then they focus on chromosome 21. So that is the most of the labs are doing, and then that is the best test that can be done. Next. So which is the best test is massive parallel sequencing. Whom not to advise a test, this cell-free fetal DNA. When on ultrasound you are detecting a major malformation, anyway, either you will terminate and do a karyotype, whatever molecular testing you need to do, or you will do straight away an invasive testing. And in a couple where there is an indication of going ahead and doing an invasive testing, because the couple is, the fetus is at higher risk of single gene disorder, like for example, couple with beta thalassemia carrier. The fetus has 25% risk of being affected with thalassemia major. So anyway, you are going to do an invasive testing. That same sample can be subjected for chromosome 21 analysis or karyotype and then subsequent testing. Next slide, please. So in those conditions, you need not do a cell-free fetal DNA and extra cost to the patient. Where you need to be careful, twins, higher order pregnancy. I have one slide for twins. Vanishing twin. That vanishing twin, the placenta will produce some amount of chromosome, DNA, will interfere with your result. IVF conceived, donor ovum, renal transplant on dialysis, and cancer with pregnancy I have already discussed. Next slide, please. So what do we do? So what points to know is false positive is can happen in maternal mosaicism, rarely in occult maternal malignancy. There are reports maternal malignancy being recorded or reported following an NIPT or cell-free fetal DNA. So there can be 4 to 8%, roughly around 6% no call, or the lab cannot give you a report, which is called as a no call or indeterminate result. So in no call, advise amniocentesis. Earlier it was said that if there are twice there is no call, then only you go ahead and do amniocentesis. These days, the repeat failure rate is 40%. So you straight away go ahead and do a invasive testing. And if it is more than 16 weeks, it is amniocentesis. If it is less than that, then you can do a CBS. Next slide, please. So sensitivity of integrated test, or if I integrate, the base test is on my left hand side and on my right hand side is cell-free fetal DNA. For chromosome 21, 18, 13, everything, that the bars are taller than the corresponding on my left hand side. So it is a better test for all testing. Next slide, please. So we land up in screening all these 100 women, and that is what I have made them. Like these are 100 women. Next slide. Next, just press it. So there are no, probably you press twice. Yeah. So there are no. Just go back once. Yeah. So there are 6 women who are screen positive. And once you do an invasive testing to these 6, only 6, press it. So this is the woman who is with the tears that I have made it and is truly positive. So you are finally at the end of the day, you are doing 6 women invasive testing, and of which 1 is having a trisomy 21, rest 5 are not having trisomy 21. So they are normal. So you should remember that screen positive doesn't mean termination of pregnancy. Next slide, please. So screen, and it's a screening test. If high risk, then invasive prenatal testing. And we must remember that positive predictive value depends on maternal age. Next slide. So what I have made is a 30-year-old primee was advised NIPT and report suggests high risk. What do? You do an invasive testing, you do termination of pregnancy, or you do counseling and continue the pregnancy without doing anything. So next. So what we need to know is we need to know about this cell-free fetal DNA or NIPT, what is positive predictive value? And the summary of it is, out of the total positive that we get after doing a test, how many of them have got truly a disease? So that is positive predictive value is A, those who have got disease and screen positive upon total positive, or those out of total positive, how many of them are truly positive? Next slide, please. So just to highlight that, if the maternal age is 30, as in this case, for trisomy 21, positive predictive value for cell-free fetal DNA is 61%. So of your number of samples who turn out to be positive, say for example, 100 of them are positive. If the woman is 30 years, then 40 will be normal. So cell-free fetal DNA is good if the woman age is more, that is 35, more than 35, it is 40, at 40 years of age, it is 93%, 45, it is 98%, but in a low risk or a maternal age less, a positive test doesn't mean that fetus is affected with trisomy 21. You should not go ahead and do a termination of pregnancy. By that way, 40% of normal pregnancy may be terminated if the maternal age is 30 and she has got a NIPT which is positive. Next slide, please. So this is NIPT high risk. It's the same patient who had that 2 tests on the same day, ordered on the 7th of July. And it is the report of that same patient. And both the reports luckily said that high risk. The double marker said 1 in 12 and the NIPT was high risk. Next. So we did a invasive testing and the fetus was turned out to be trisomy 21. We have terminated this pregnancy just few days back. Next. So counseling is most important before doing any test and post-test. After getting the report, all women have an option of screening. All high risk should be offered invasive prenatal testing. High risk, I mean that those who have a screening test and then has turned out to be high risk. Please, in high risk cases, you please do not go ahead and do an NIPT testing, which becomes more confusing. Even if woman opts for no screening, ultrasound to be done to rule out malformation, routine antenatal care to be continued, and above all, our documentation has to be very, very strong. Next slide, please. Number of fetus wrongly noted. Difficult situation is number of fetus wrongly noted. Types of twins not taken into consideration. Vanishing twin, fetal death, fetal reduction. Patient, all type of cases we have encountered. With fetal death, double marker being done and then has been sent. Exogenous HCG is a very, very common practice. Patient not willing for invasive testing. If the patient is not willing, no point doing the test. Next. So, one slide for screening in twins. First, we determine chorionicity. If it is monochorionic, then we take the NT of both the twins, average the NT, and this NT is considered as 1. Then take the maternal blood, do the double marker, and with this NT, we do the combined screening. And this is one risk that is obtained in monochorionic. They have got the same chromosomal pattern. It's a monochorionic twin pregnancy. Whereas in a dichorionic, you take 2 NT, inform that they are dichorionic and send that there are 2 different NT. So 2 different NT are sent. So you will get 2 different risks. And so for knowing that which fetus is at a higher risk, you first label the fetus as A, B, or 1 or 2 on the maternal left, maternal right, up, low, and then do the NT, and then accordingly you determine which, if both the fetus are low risk, high risk, or one is high risk, another is low risk. Next slide, please. So each patient should have an option of prenatal diagnostic testing. A risk of 1 in 1,000 may be high for one, and a risk of 1 in 100 may be low for another. So we must respect patient decision and then follow it. But however, the facility of invasive testing should be available to the patient. Next slide, please. So principle of this testing is traditional screening should be done for all low risk. That is what I mean by traditional screening is our double marker and NT, rather NT and double marker. And if you are able to do a nasal bone, that enhance your sensitivity. In high risk, you need to go ahead and do a cell-free fetal DNA. And those invasive testing are those malformation and single gene disorder. Abnormal traditional screening test result is followed by a negative NIPT. Your double marker shows a high risk. Your cell-free fetal DNA is normal or negative or a low risk. Still, there is risk of chromosomal abnormality in around 2%. So please remember that a high risk in your first screening should not be offered another screening test. That is as simple as that. Traditional screening is not recommended after cell-free fetal DNA, and concurrent screening or parallel testing is not recommended. Next slide, please. So just today, 27 September, today is 27 September, I have this patient in my OPD right now sitting. So she is, just press it, next. She has got this report, 35-year-old, 4th gravida, 1 living issue, 2 MTPs, ultrasound done at 7 weeks, double marker, advised at 13 plus 4 weeks, done, serum taken at 13 plus 4 weeks, risk is 1 in 184 and referred here. So where all, on what steps we have gone wrong in this management of this patient. Next slide, please. So what has gone wrong is only serum screening is done without NT. So we directly jump onto 60%. No ultrasound done before double marker is advised. The first ultrasound that was done at 7 weeks, no further ultrasound. There may be a major malformation. The fetus may be anencephaly. And may have major malformation or maybe intrauterine fetal death. We do not know. She is 35 years old. By the time she delivers, she will be 36. And then straight away we could have done a NIPT rather than doing a serum screening. So she fits into a NIPT. So for this patient, we have gone wrong on all these steps. Next, at least we need to learn and then modify ourselves so that 20% of my OPD attendance is because of this confusing serum screening, this thing. So offer serum screening to all, but please understand what you are offering. Do not mix and match. No mixing matching. In race, it is okay. In fashion, it is okay. But patient management is not fashion. So double marker, quadruple test and NIPT should not be mix and match. Combine serum marker with your ultrasound, a blood test and an ultrasound test. Low risks only follow up, high risk invasive testing. There is no shortcut to it. All high risk should have an invasive testing. Intermediate risk needs further testing. So if you are expert in an ultrasound, you look for all those additional markers that I talked to you in the first setting. That is ductus, TR. Then there are some angles that can be looked into. People like Dr. Anita Cole will look into even the fingers, then the clinodactyly and the sandal gap. But it's not if you possible, then you look into that and modify your risk and put the patient on only follow-up or invasive testing. Next slide, please. So stop beta-HCG at least 2 weeks before serum screening. Be careful of fetal demise, vanishing twin and twin pregnancy. I've highlighted this point many a times with my past experience of seeing such reports. Serum markers may indicate adverse pregnancy outcome. So look into your MOM. And these 4 tables that I have quoted is from Green Journal. And then that can be pasted into your clinic and then looked for. So that you may encounter IUG or you may pick up, prevent a fetal demise. Next slide, please. So I thank you. I'm really sorry for this mess up of my new laptop. Actually, I've got this laptop new, happy about it, but then still meshing up. Probably I will learn. So promise to learn. Then next, yeah, I have got, so you can have a Down syndrome and then this prenatal diagnosis and a normal healthy child. Here is Down syndrome and then the second child is Down syndrome. So should I do a practice like this? Never. So what we need to do is we at least prevent even birth of that first Down syndrome. Gone are those days where Downs and after that we are picking it up and being happy. We need to prevent the even birth. Thank you so much. And I thank Dr. Sadhana Gupta for arranging this. And I'm really sorry for rushing down then this thing. And I take this opportunity to inform everyone, those who have joined and joined online, is please, 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 it is we who can prevent RH isoimmunization. We are loaded with patient of RH isoimmunization requiring fetal transfusion. Almost every month we have got 15 to 20 new patient of RH isoimmunization adding on to our kitty. So it is our role to prevent it. Please prevent, along with Down syndrome, prevent RH isoimmunization, which is easier. Thank you so much.
Thank you, ma'am. It's been wonderful. I'll ask my experts, Dr. Deepika, to give her comments.
Right. So Dr. Mandakini has really shown us very important steps in the prevention of Down syndromes. Of course, RH isoimmunization we are not discussing, but it's very, very important, all the different types. Mandakini, I must say that I still get, and I think it's a tradition in private practice, that everybody does a first trimester screen and then they again do a second trimester screen along with an NIPT. I mean, it's quite a routine sort of a thing that NIPT is offered as a first line also in most cases. But I agree with you, it's not cheap, it's not standard as yet. But in that case of yours, where she was 35 years, I think these are the cases where we can offer them as a first line. But at the same time, we also do the ultrasound in the 11 to 13 plus 6 weeks scan part. So I'm sure there would be a lot of questions. There's nothing for me really to add, but I too had a case where the first trimester screen was normal. Obstetrician also did the quadruple screen, and that was high risk. And synthesis, the fetus had trisomy 21. So there was no way that I could actually ignore the high risk screen report of the second trimester quadruple screen, though the first trimester was normal. Another problem which arises is the screen is normal, the NT&B screen and the double marker screen is normal, but in the second trimester they come up with a malformation which is suggestive of a chromosomal abnormality. And then you need to do an amniocentesis though the screen was negative. So there are, as a referral fetal cases. So I would say that the obstetrician should definitely know how to screen, when to screen for Downs, and then refer them to a fetal medicine specialist when there is a little complicated report. So thank you, Dr. Mandakini. And thank you, Sadhana, for giving me this opportunity.
Thank you, Dr. Deepika. Now over to Dr. Prerna Agrawal. She wants to give a few comments.
First of all, I would like to thank Dr. Sadhana for giving me this opportunity, and I feel honored to be sharing my platform with stalwarts like Dr. Deepika and Dr. Anita, who are actually the fetal medicine experts. But as a person who's sitting at the periphery and doing a private practice, what I feel important is that we all need to be aware of the available options of the screening first. Second, what is the best window to do it? Many a times you're getting patients who are coming at 14 weeks plus and they are wanting to go for a double marker test. They are coming with a bad obstetrical history, and that is the time when we really lose that first trimester window. So that is important that we need to be aware about. And following that, what is the how to sort of interpret it and to get that best window where we can go for all those further advanced testing or the invasive testing. So that is something which I feel needs to be spread wide and fast at the periphery also, so that we can get the best output from that. Thank you.
Thank you, Dr. Prerna. Dr. Anita, your inputs are required now.
Thank you all very much. Really nice to see everyone of you, including Dr. Prerna. I think what you said was absolutely valid, because that window period needs to be there. The other thing that I feel which is really important is our quality control, because we are talking about screening and different things, but we are not talking about that if the NT has to be done, you need to ensure standardization, and that the obstetricians can do. It's not, I think that they are willing to accept anything and everything, and I think that has to change, because unless the quality comes from the obstetricians, the radiologists and the sonologists are not going to change. So I do think that that is important, and it's important for us to do the FMF standardization. The point that Dr. Mandakini made with the confusion with the first and second trimester, I totally agree with that. So what we do is that we are absolutely, we are so sure of our first trimester. For us, the first trimester's combined test, which is what you recommended, Mandakini, and which is what is recommended the world over, is foundation. It is so strong. So if our first trimester is so strong and the risks are better than, say, 1 in 5,000, we don't even do a quad. We say that we are so confident that first trimester was great. The risks are more than 1 in 5,000. It's a sort of arbitrary number that we take it as 1 in 5,000. So we say that we won't do anything and we'll go straight to the anomaly scan. If by chance it comes as an intermediate risk, if it comes 1 in 700, 800, and at the moment, most people take, say, 1 in, those hundreds as an intermediate risk, then the obstetricians have a choice. The best is for them to do a NIPT. But if the patient can't afford it, then do a quad. So the point is the quad is slowly dying out because the first trimester is replacing second trimester screening. So second trimester is a default test just because the person has missed first trimester. But the first trimester has to be excellent. And now I feel, at least in Delhi and surrounding places, we are giving out really good results. So that's one thing. The second thing where I find the obstetricians mess up a little bit is where there have been embryo reductions for some, and the IUDs that you mentioned, Mandakini. You cannot do biochemical screening after that. You really can't, because it gives inaccurate results. If you've had an embryo reduction, you cannot order a quad. If you can, there's a twin pregnancy and one of them has died and you can see the fetal pole, you cannot order biochemistry. So those things need to be taken into account. But I think we are getting there. We're definitely much, much better than we were some years back. And I'm glad this happened. And Mandakini, you pointed out all the practical things, really. But would you say the take-home message is do the combined test, but do it really, really well? That's the take-home message.
Yeah, that's true. That's very well summarized. That do the combined test, do it well, give all information.
Yeah.
Do not give HCG. So take care of all those factors and then do it. Yeah.
One thing which I wanted to share at this point of reduction, Dr. Neeta, had a patient who was carrying triplets, and then she had to go for a reduction. So I referred her to Dr. Chitra. She is also there on the platform. And after that, the test did show some intermediate sort of risk. And as a fetal medicine expert, I took her advice and we continued with that pregnancy. She's doing fine as of now. So that was a point which was relevant, yes.
Okay.
Nice.
Thank you, Dr. Sadhana. All the best for the Foxy elections.
Thank you. Thank you. It was wonderful deliberations. Thank you. All the excellent deliberation and excellent inputs from experts, all experts. So, Vanda, we can go to the second session.
Now we go on to the. Should I, Shravanti, you are sharing or I share the screen?
Ma'am,
Shravanti is going to share it.
Okay, Shravanti, you share then.
Be very, Ritu is there, be very, very quick in CVs.
Yes, ma'am. Yes, ma'am.
Really, because Dr. Mandakini has set the stage for all the panel discussions.
Yes,
so
yes, ma'am.
Definitely. Very quick in CVs, yes.
Very quickly, ma'am. Well, good evening. Now it's time for panel discussion. Topic is solving enigma of ultrasound soft markers. Our moderator for the panel discussion is none other than, I would say, pride of GOGS, Dr. Sadhana Gupta, ma'am. although volumes can be said for her, but I'll make it a little short. Madam is president of NIGF and she's recipient of innumerable awards, and she's written many papers also. Our knowledgeable expert for this session is Dr. Aparna K. Sharma, ma'am. Can I have the CV, please? Shravanti?
Yes, ma'am.
Are you there?
Yeah.
Dr. Aparna K. Sharma, ma'am. You come on to the session 2. Yeah, after this, yeah. Yeah. Madam is additional professor, All India Institute of Medical Sciences, New Delhi. She is Secretary, Society of Fetal Medicine, and she's North Zone Coordinator, Safe Motherhood Committee. Our galaxy of panelists include Dr. Anju Jain, Shravanti, Dr. Anju Jain, CV, please. Yeah. She is Director, Jain Hospital, Varanasi. Then Dr. Moni Bhatia. She is Chief Clinical Geneticist and Fetal Medicine Specialist, Noble Hospital, Rohtak. Dr. Aditya Garg. He is Consultant, Garg Maternity and Surgical Center, Ambala, Kant. And he is ex-consultant, Feto-Maternal Medicine in UK. Then Dr. Neha Gupta. She is Consultant, Fetal Medicine and Genetics Department, Kailash Hospital, Noida, and has special interest in fetal neurosonography and advanced fetal interventions. Dr. Aradhna Agarwal. She is fetal medicine. She is head of the Department of Fetal Medicine, Department Apollo Hospital, Amritsar. Dr. Chitra Janu. She is the owner and consultant fetal medicine at Dr. Chitra Fetal Medicine Clinic, Agra. Then Dr. Shruti Jain. She is consultant fetal medicine and genetics at Kailash Hospital and Neuro Institute, Noida. I welcome all of you for this brainstorming session of panel discussion. Now, over to Madam Sadhana Gupta.
Thank you, Ritu, and we welcome all the panelists, and again we welcome all the august dignitaries and the faculties and the audience with us. Let me just first, so before I go to the first slide, so it is the typical NIGF flavor. It is, we have the experts, speakers from all the 7 states of the North India, and that is the beauty of NIGF. So are we lost? We say, are we lost? It is, I am taking it is not from my side, but from a very, very recent paper. So thank you always for being together for so many platforms, so many workshops, publications, and everything. So welcome all the panelists. And what is soft actually? Soft may not be visible to many. It may whisper something significant, may be benign, yet observer can have knee-jerk reaction, and they may cause sometimes false anxiety and apprehension in clinician and the family. So it is all about that we need to have the universal, some sort of screening, and the best screening for our all patients. And we have a lot of things like age, biochemical, what Dr. Mandakini have said. So coming straight away to the point, Dr. Anju, we wish to know from you that what ultrasound markers, it is over first trimester screen, biochemical screen. When you do second trimester ultrasound, what marker you think that these are the major marker and these are soft, and why they are called soft markers? Anju, over to you.
Thank you, madam. Once we are doing a second trimester scan, we should look for the major structural defects. If we are seeing them, that constitute the major markers. If we are seeing any CNS defect, ventriculomegaly, any holoprosencephaly, these are the any bone defect, any facial defect like cleft lip, palate, or in the neck we are seeing a cystic hygroma, those which constitute a structural anomaly. They constitute a major marker. They can be in any of the system, CNS, skeletal system, facial system, or in the limb, if any limb defect is there, if there is a cardiac endocardial cushion defect, if we are seeing any abnormal, those septal defect doesn't constitute a major malformation. If it is a hypoplastic left heart, TOF, or and if we are looking for the soft markers, they are basically the normal variants. They are non-specific, but they point towards increased chances of aneuploidy. We have to look for the soft markers, which includes nuchal fold thickness, echogenic cardiac focus, echogenic bowel, rhizomelic limb. In that too will be a short humerus will be more important than a short femur, or mild atelectasis. These would include the soft markers, but their presence will not warrant that it is an aneuploid fetus. It will just enhance the risk. We have to see if there is a single marker, or there is multiple markers, or if the marker is associated with any structural visible defect. And that's the way we have to interpret our ultrasound finding. And if we are seeing even if we are seeing a single soft marker, that warrants a detailed anomaly scan, not to miss out any structural defect which could have been missed if we were not very cautious.
So thank you, Anju. You have set the stage, and let us, like audience, must be clear that what are the soft markers to look at and what are the major markers. And today we are focusing on the soft marker and how they are significant. So one important point Dr. Anju has highlighted, that they can be present in normal fetus, yet they point about something which may be related to aneuploidy or maybe some other prognostic marker. So thank you, Anju, for setting the stage. Dr. Moni Bhatia, the question to you is that what is the concept behind soft marker, and in current Indian scenario, what you see, what is the role and place of soft markers in a routine of antenatal care for the benefit of everybody, so that we have a real place of soft marker in our antenatal care. Moni, your comment about the concept.
Thank you so much, ma'am. Basically, soft marker, as has rightly been discussed, that these are not any major malformations, but these are the minor malformations which do not have effect on the normal babies, but they increase the risk of aneuploidy. As far as the Indian scenario goes, it should be a universal screening for soft marker in the routine level 2 scan. First, it can be easily detected in the level 2 scan, and it also prompts us to go ahead with the aneuploidy screening. The aneuploidy screening should be a universal screening, but in Indian scenario, still it is not a universal screening being carried out. If it comes out to be positive, if we see any soft marker, we should go ahead with the aneuploidy screening. And apart from that, these soft markers does not only tell about aneuploidy, but these gives us a lot of information, like targeted ultrasound is required if we get any single umbilical artery or any other soft marker is present. Look for cardiac abnormality or renal abnormality. Also, the follow-up ultrasounds are required if we look for the single umbilical artery or echogenic bowel. I mean to say, if any soft marker is identified, we can go ahead with the aneuploidy screening. Apart from that, follow-up ultrasounds are required, and the targeted ultrasound should be offered to look for the other associated abnormalities which can be seen in association with the soft marker.
Thank you, Moni. So this slide really says that in soft markers, we can have around 57% actually no problem. And with 24%, there can be aneuploidy, but it also points to other things. That is the structural defects, single gene microscopic, and the other chromosomal aneuploidy, which are not so common. So this is very important that we must understand each and every soft marker, so that every obstetrician is quite clear that what to counsel this. So in Western world, there is an issue that there is a higher invasive test when we use soft marker, but in India, actually we are facing, there are very few institutions who are really updated, and in metros it's okay what Dr. Prerna says. In periphery we don't get, and the people don't also accept the invasive procedure. So soft markers are some way to help us out, and it is not to make the things more complex and the more dicey for the patient as well as the clinician. So Dr. Aditya and expert, if Dr. Aparna has joined. What you think that when you receive as a fetal medicine specialist, and we will say right from the, like any person who is ordering ultrasound second, what we say label to ultrasound or anomaly scan, do you really counsel that there can be possibility of something like soft marker where, because the research says that the patients suddenly feel very traumatic when they are explained because they are ready only for a good scan. So Aditya, what's your comment that how we say pre-biochemical screen counseling, pre-aneuploidy screen counseling, it is same about the soft marker evaluation as well. Aditya, your comment, and if Aparna is there.
Ma'am, my standard counseling for an anomaly scan always begins with telling a patient that I'm looking for abnormalities. The scan will not diagnose all abnormalities. So that is the pickup rate is about 60-70% at best. And I also tell the patient we may find findings which may not be a problem in the fetus, but which we may need to look at in detail, either later on in pregnancy or do some specialized targeted scans. So it is my standard practice that I tell my patients that soft markers may be noted. However, my list of soft markers is much smaller than what currently is being shown here.
Yes,
so
yes.
Personally don't include echogenic intracardiac focus in the heart or CPCs in my list.
Great. So Aditya, very, very golden message from Aditya that when you order any anomaly scan or the second trimester scan, please counsel that we have the limited, we cannot diagnose every anomaly. First of all, many anomalies are detected in third trimester, many functional, they are not detected at all. And secondly, that they should be emotionally prepared that for what purpose it is being made. So because what we say, the positive pregnancy experience and many things that the people are frightened after too many tests, too many results, and they really don't know what to do. So golden message from Dr. Aditya that we should counsel everything, what we are going to look for, what we are able to look, and what we are not able to look, and the fetus which need to be get the follow-up in the second or in the late third trimester. So golden message. And Aditya, you are right that we will also discuss because the people are coming with the CPC and the echogenic intracardiac foci. So we will come to that how it is not that important. So it is important message that make everything very, very positive in our antenatal care, because the sadder aspect of life in 21st century is that science gathers knowledge faster than society gathers wisdom, and society includes us also. So this is very, very important, and we have to respect everybody's viewpoint. So we are going the Aparna, if Aparna is there, NIPT, I think Dr. Mandakini has given a very, very clear idea about this NIPT. So any final comment if Aparna is there, or Aditya, if you can take this thing, where you see NIPT role in our Indian resources, though Mandakini has done it. So Aparna, are you there? So Aditya, you can take this very, very quickly.
Ma'am, the whole question of whether NIPT is beneficial or a drain on resources depends upon the availability of enough people who are doing invasive tests. So in case there is a landlocked region where there is no availability of a fetal medicine specialist to do an amnio or a CVS, well, the only solution left then is an NIPT. So for good or bad, that might be the only solution you may have if you're working in a remote peripheral town.
So thank you, Aditya, once again, because there are few indications where Dr. Mandakini says that the NIPT has role with its own limitation and with its own issue. But important thing is that at the periphery, at many places, there is no availability, or the patient actually cannot go to that center for the invasive test. Then NIPT has got its role. Very, very important that even a little costly test can be utilized in a select number of the couples. Very, very important message from Dr. Aditya. So one comment from that, it is high risk versus low risk population. We always say that it is high risk and the low risk population, and we have to be very, very careful when we are interpreting any soft marker or any interpretation in form of that. Like like in previous, all the experts says that how we can diversify our obstetrical population in a low risk for aneuploidy and the high risk for aneuploidy. So now coming to with this background about soft marker, let's understand one by one and from head to toe. So Neha, this question is for you, the isolated ventriculomegaly. So Neha, what is cutoff? Just now, yesterday, I got one query in one academia group that it is ventricle 8 millimeter and they say that it is ventriculomegaly. How do you measure? And when there is ventriculomegaly, you consider only aneuploidy or the other thing, and how your tips for counseling, that how this couple should be counseled. Neha, the question is for you.
Thank you, ma'am. So ventriculomegaly is defined as more than 10 millimeter at any gestation throughout the pregnancy. So any 10 to 12 is mild, 12 to 15 is moderate, and more than 15 is severe ventriculomegaly. The lateral ventricle is measured at the level of transventricular plane. CSV should be clearly visible along with the anterior horns. Then we see the lateral ventricle, and at the level of the parieto-occipital fissure, that is where the glomus of the choroid plexus is, you take the measurement from inner to inner. That means the plus sign of the cursor should be just lying on that inner line, and that's how you measure the dimensions of the lateral ventricle. 8, 9, 9.5, they are all normal. As long as the value is less than 10, it is not ventriculomegaly. Any value more than 10 goes ventriculomegaly. Now, ventriculomegaly is actually a sign. It is not in itself a diagnosis. That means we need to look for other things also. The first and most important thing is that one, you need to do a detailed ultrasound and look for other structural abnormalities, other soft markers that could be pointer towards aneuploidy. So one, if you do not find any other marker, the first trimester screening was low risk, and the neurosonogram is also fine. It could be a normal variant also with a more than 90% of a normal outcome. But you have to counsel that in 5 to 10% of the cases, it could be associated with aneuploidy. The most common cause is trisomy 21, but it could also be associated with variety of other genetic syndromes. And it is said that in isolated ventriculomegaly, the abnormal pathogenic copy number variance, usually you get in the range of about 3 to 4%. It could be a marker for an underlying 40% of the cases are associated with the other cranial or extracranial abnormalities. So a detailed ultrasound. Cranial abnormalities may not be apparent at that point when you're doing a level 2. So it could be a marker for an underlying abnormality like a cortical migration disorder, like lissencephaly and all, which might be evident at the later stages only. Then you look for the markers to rule out fetal infection, especially CMV, which in 10% of the cases could be associated with aneuploidies. So if you do not find all these issues, then in majority of the cases, it's actually having a good outcome in more than 90% of the cases. So what we suggest to the patient is doing a detailed ultrasound along with the echocardiogram as well as a neurosonogram. If that is all okay, offering an amniocentesis along with QFPCR, which rules out the common aneuploidies, and along with chromosomal microarray. If that is also okay, then you follow it up after 2 weeks to see the progression. Because in 5 to 10% of the cases, it might progress also. So if it progresses, it is a harbinger of maybe an underlying brain abnormality or an underlying severe, maybe a cortical migration disorder. And do maternal serum serology, and depending upon the results, you can order a PCR on the amniotic fluid if you're already doing an amniocentesis. If all these tests are okay, and also on follow-up, you don't find it's remaining stable, then you can also reassure the patient, but always counsel the patient that it could be a marker for underlying brain abnormalities which might not be detectable at this point of time.
Thank you, Neha. It was wonderful that the ventriculomegaly, first of all, right measurement, and every obstetrician must know that what is ventriculomegaly. It is more than 10 millimeter. This is very important. And secondly, it is the one marker of the aneuploidy soft marker, but also look for the other thing like a detailed scan and the congenital infection. Somehow torch is being either very, very over abused or sometimes it is totally neglected, but still, especially in patients with bad obstetrical history in India, we do get toxoplasma and CMV. And when you are doing amniocentesis for like ruling out aneuploidy or confirming aneuploidy, it is always better that in these cases you look for the PCR for the CMV and the toxoplasma. And that one comment what we say that if the patient is having everything is fine, even then the babies with the ventriculomegaly need that they should be followed for the neurodevelopmental growth and what is their outcome, because in 6% for the moderate ventriculomegaly, it is a neurodevelopmental delay, and the 7% in severe. So it is around 6 to 7%. So ventriculomegaly is a very, very important soft marker, which has the implication in aneuploidy, as well as the implication beyond that, that is fetal infection and the primarily brain disorder. So this is the very important message from Dr. Neha and all the experts. Any person want to comment on this ventriculomegaly before we go to the second soft marker? Any panelists wish to have any comment on this?
In
yes.
case we do find that a case of ventriculomegaly is not settling down, like Dr. Neha said, in 2 weeks or 4 weeks or whatever your cutoff is, it may be prudent to offer a fetal MRI to that particular patient. Fetal MRI is one of the most kind of important investigations as far as neurosonogram is concerned. It will always look at the fetal brain in a way that you cannot look at with an ultrasound. So
thank you, Aditya, for updating this, that the fetal MRI is also a reality, and in certain situations we can utilize that fetal MRI. And let's see that how in the next next 4 or 5 years, how the fetal MRI is going to really change, because autism and the cerebral palsy and the cognitive development is the one issue which our technology in 21st century is not able to tackle that well. So Aradhana, the second soft marker is for you, choroid plexus. So Aditya says that he doesn't consider it as a soft marker, but do we really do get ultrasound with this reports, and your message that how we should take choroid plexus is Aradhana.
Thank you, ma'am, and good evening, everyone. So you asked me, how do you react to their presence? Well, we definitely should not panic, first of all, because it is, as you know, it's not a very important marker, first of all. It's present in normal pregnancies in almost 2.5% between 16 to 20 weeks, very commonly seen. In fact, after 20 weeks, up to 23 weeks, they begin to regress. And in fact, after 26 weeks, you can hardly even see them. It's not even a soft marker for trisomy 21. If at all it is associated with trisomy 18, that too with an isolated likelihood ratio of 1.5, T18 we must understand is a spectrum of other structural abnormalities. So you wouldn't really have an isolated finding of a CPC per se. The next thing, of course, is to know how to measure this. So it's an interventricular cyst, and we would be seeing it in the transventricular plane. It doesn't matter if it's round or oval, single or multiple, the size doesn't matter, unilateral or bilateral. It does not alter or increase the risk of aneuploidy. So we don't really have to worry about it. And we should counsel the patient accordingly. We will continue to monitor them, to follow up, to alleviate their stress in the weeks to come. And even if it does persist at all, you can follow up the child in the postnatal period, but you would just look for, any adjacent effect on the brain tissue, but really not much to worry about.
One thing, Aradhana, that this is the thing that there is a CPC, then you should have a detailed evaluation of hand that is shown to be a related correlated. So your comment on that.
Yes, of course we should see the hand, because you're thinking about a clenched fist in trisomy 18 and the association is almost 15%. So yes, we are prompted. CPC per se might not be so important, but it does prompt you to see, for a further detailed genetic sonogram. If not already done, it should be done by an expert to validate its isolation.
Thank you very much. And another important message is begin by the ventriculomegaly babies need to be looked for the neurodevelopmental issue. The CPC presence is not associated with the long-term neonatal outcome and the cognitive effect. So because we want to give this message to all audience, because so many times we get the report from the expert, it is CPC advice amniocentesis. So CPC is not considered as that soft marker for aneuploidy. It is not related to neurodevelopmental delay. It is only important when you have a detailed scan and or you have a multiple soft marker. So the message was very clear, and we wish that all audience and all the practitioners are very, very clear about it, that it is not an indication for invasive testing, and the risk does not alter with size, unilateral or bilateral choroid plexus cyst. So thank you very much, Aradhana. Now coming to the another very important absent nasal bone. So Chitra, your comment, how should you visualize any comment on racial difference or the ethnic difference? And when we see it is a hypoplastic nasal bone or absent, what are the implications on our antenatal care and counseling? Chitra, your comment.
Thank you, ma'am. Visualization of nasal bone is important, very important part of the level 2 scan. In fact, we have to see it in the ND scan itself. And it's we have to be very sure that how we measure it. The baby, we have to make sure that the angle of insinuation should be approximately 90 degrees, because if the neck is hyperextended, then we might falsely measure it smaller in size. And you have to make sure that you're absolutely in the sagittal plane, mid-sagittal plane, and not in the parasagittal plane. And how you make sure that you should be seeing the CC, that is corpus callosum in the vermis. And also you should be able to see the hard palate and the vomer in the midline. So when you see that and you're sure that it's midline, and that's how you measure it, the nasal bone. And if the nasal bone is very small, hyperplastic, there are a lot of nomograms present to see where some that you can see whether some say less than 2.5 centile, some say less than 5th centile, and at least. But if it is very less, like less than 2.5, definitely it is an hypoplastic nasal bone, and you can have unilateral hypoplastic nasal bone. So make sure that you check both the nasal bones.
Thank you. One thing important, because now we find I get calls from so many part of India that there has been to say that it is absent nasal bone and the couple want termination of pregnancy because our child will not be in a good shape or mentally retarded. So I really want you to tackle this issue and the clear message to all of audience who are with us.
Yes, ma'am. So nasal bone is a very strong soft marker. It has got likelihood ratio of around 6.5. So absent nasal bone, you cannot ignore it. But yes, then it is, you have to test the baby, because hypoplastic nasal bone is very common in Asian population. If you follow the nomograms of the Caucasians, so you may we have so many false positive hypoplastic nasal bone, so called. So, but you have to test them. You cannot ignore them. And even if you have had a low risk screening in the first trimester, dual marker low risk, I would personally always do amniocentesis and invasive testing for these because it is a very strong marker. And once you test them, and if most of the times these come out to be normal babies, but you cannot ignore a hypoplastic nasal bone. That's my message.
So thank you very much. So message is very clear. First of all, do look for the nasal bone. That is very important. And 0.5 to 2.8% of euploid fetus can have delayed ossification. There is an issue of the racial and ethnic variation also, but it is a strong marker and you cannot ignore it, and it is needed. So Chitra, your comment that now usually the people say for the karyotyping, but if it is nasal bone, the microarray or all, or it should be for the select group. So what's your comment? Because the clinicians are not keeping that pace with the advancement in genetics. So what's your say? What we should do? Or leave it to fetal medicine expert?
Ma'am, yes. Yeah, I would suggest microarray, because karyotype is very basic, and whatever most of the things we want to pick up in karyotype, we will definitely see in microarray. And we will be able to pick up more details in microarray, and deletions and duplications are better picked up in microarray. So definitely microarray is preferable to karyotype.
So thank you once again, because microarray is the way ahead, because we are really not only focusing only the 3 aneuploidies, but we are looking for the other chromosomal disorder also. So Shruti, coming to next important soft marker, that is thickened nuchal fold. So how you do your measure, what is normal, what is abnormal, and when we find it, what are the implication and what are the clinical decision to be made? Shruti, you.
Yes, thank you, ma'am. Actually, nuchal fold should be measured in the axial plane, where we should be seeing the CSP, the cerebellum, and we should be measuring the nuchal fold from the outer edge of the occipital bone till the outer edge of the skin. But here it is very important, because we recently have a paper in which they have shown that if there's a 30-degree tilt to this image, it has been shown to reduce false positive rates. It is very important. We have seen in clinical practice as well, and it is a very important point. So whenever we are measuring nuchal fold, it's better to have a 30-degree tilt, and also it is shown to give slightly higher false positive rates if it is a breech presentation. So we should measure nuchal fold, measure it properly, and also when we are measuring soft markers, I feel it is very important to avoid false positives as far as possible, to avoid unnecessary anxiety also.
So thank you. Yes, and what is your cutoff? It is 5 or 6? What is your clinical?
6 millimeters we take as the cutoff. And once we see the increased nuchal fold, yes, it is very important to do a detailed assessment to see for other soft markers, and also to see have a very detailed cardiac evaluation to exclude any cardiac malformations if they are there. And it is a very strong marker for trisomy 21 per se. So it is always a good idea to offer patient invasive testing with microarray to rule out trisomy 20 and other micro deletions or duplications. And if there are no resources for invasive testing, then yes, we can offer NIPT.
So very important that the nuchal fold thickness is very important, right technique, right plane, and it is always better that the ultrasonologist or anybody who is doing a scan gives the image. So we are really sure that the image has been taken in a right way and the measurement has been taken right way, because that is also very, very important. And this is very strong marker. Again, it is important after absent or hypoplastic nasal bone that these women should be advised amniocentesis or the confirmatory test, and if it is not available, then we can use NIPT for some way. This is important when you see that the karyotyping or the amniocentesis is okay or the NIPT is okay. Do you think that it has further implication beside aneuploidy? Arparna, you are there, or Chitra, you take over that, or anybody who wants to take? Beyond aneuploidy, nuchal fold thickness, if it is fine, it is the baby is euploid, then it has different implication also. Chitra, you can take over this question. Hello, am I audible?
Dr. Chitra, please unmute yourself.
So, ma'am, and thickened nuchal fold is a important soft marker, and it cannot be ignored. And yeah, if you haven't had an NIPT which was low risk, and then I think you can ignore it. But otherwise, definite testing is advisable when you're thickened.
Ma'am, can I add something?
Yes, please, Neha. Yes.
So a nuchal fold thickness is a very important marker. So if I see it in the second trimester, I will not offer NIPT or will not look at NIPT even if it is coming out to be low risk. If it increase nuchal fold, I will offer amniocentesis for QF-PCR and chromosomal microarray, because besides trisomy 21, it could be associated with variety of other problems also, like rasopathies could be associated with it. So increased nuchal fold thickness, even if you have a low, even if you have an NIPT which is low risk, you need not ignore. You should not ignore it, and you should offer invasive testing in that situation. And the testing, the choice is not karyotype; it is microarray. So we do high resolution microarray 750K. Along with it, we do counsel the patient for single gene disorders also, or we might order a panel or something, but we might store the DNA also along with it so that the couple can decide whether they want to go beyond microarray or not for testing, because it takes time. So whenever you have an increased nuchal fold thickness, it warrants a complete detailed ultrasounds, and we should think beyond trisomy 21. This is not the case where NIPT should be offered at all, or you should be relaxed if it's a normal, even if you have a low risk NIPT, it warrants invasive testing.
So Neha, your comment about that in the euploid fetus with the increased nuchal fold thickness, we should advise fetal echo as well. Does the fetal heart evaluation need more attention? What's your comment about it?
Yes, it needs more evaluation. If any marker that you see, and if you're seeing an increased nuchal fold thickness, increased thickness, it warrants a detailed ultrasound. In a detailed ultrasound, you do a detailed evaluation of the head, you detailed evaluation of the heart. For us, the heart evaluation includes a detailed fetal echo. So if you do not have the facility for an echo, or the person is not really, then you should send it for fetal echo specifically. So whenever we see an increased marker, the most important thing first we do is that whether it has been measured in a proper plane. Because in majority of the cases, the problem is that it has not been measured in the proper plane. So even if after measuring in a proper plane, besides having a low risk NIPT, it is still increased, it requires a detailed evaluation, which includes a neurosonogram, which includes your fetal echocardiogram. And along with it, even if I do not find any structural abnormality, I will still offer an amniocentesis to the couple, invasive testing to the couple.
So thank you, Neha. So message is very, very clear to all people that the nuchal fold thickness is very, very important. If it is taken, the technique should be very proper, and the images should be with us. And if it is there, it is more than 5 millimeter, then this is the indication for invasive testing. Karyotyping is not the method of choice. The microarray should be offered because we are looking beyond the common aneuploidy. And if it is the fetus is euploid, even then you should have the targeted fetal heart and the targeted neurosonogram, what we say that to rule out the other association with increased nuchal fold. So messages are wide and clear, and we really want to have the clear interpretation of every soft marker because we want really clear the confusion with this panel. So Anju, now coming to heart, and Aditya says that echogenic intracardiac foci, he doesn't take it as a soft marker, but still we find reports, and in some it can have some important implications. So Anju, your quick comment about the echogenic intracardiac foci.
Yes, actually we should look cardiac first. Am I audible?
A little break of voice. You can like stop your video and please talk, Anju.
Okay.
Yes.
We should look for intracardiac focus. Yes. Because first of all, we have to see whether it is not a false appearance, because it is a microcalcification of papillary muscle. Reduce the gain. Just see if that echogenicity is comparable to the bone or not, where it is located. Is it moving with the AV valves? And if it is located in the right ventricle, and if it is more than one, definitely we have to see for other defects. We should look for detailed fetal echo. As Neha has already said, we are doing it as a routine thing, and we have to see any other anomalies associated with it or not. Though echogenic focus, the likelihood ratio of Down syndrome is very less, but still we cannot ignore it. We have to explain to the attendants, and if it is associated with other soft markers like there is a short humerus, or if there is a nuchal fold is increased, then definitely I would advise this couple an invasive test instead of an NIPT. Though SFM says echogenic cardiac focus in the presence of normal NIPT, then nothing to be done. But if not, and aneuploidy screening in the form of NIPT has not been done in the first trimester. It is for the first time we are seeing the patient at this time, and we are seeing other soft markers also, or a nuchal fold. Then definitely I would advise an amniocentesis to this mother.
So thank you, Anju. You have made quite clear that in low risk population for aneuploidy, presence of echogenic intracardiac foci is not an indication for any invasive procedure. And if you have the first trimester negative screen, it is not clinical significant or it is a normal variant. Anju, your comment in low risk population, it is not important. Isolated marker, it is not important. It is not marker of aneuploidy. But in a high risk group, like a patient of 35 years, maybe negative first trimester screen, but she is having an echogenic intracardiac foci, does it have your implication or does it increase the chance of something wrong in the fetus? Anju, your comment.
No, ma'am. No, ma'am.
Yes.
No, in high-risk woman, if there is a negative NIPT report, even if the woman is 35 years, and if we are seeing a single echogenic cardiac focus, then we should not offer her an amniocentesis. Presence of a single,
thank you, Anju. It is great because everybody says, be very clear that the echogenic intracardiac foci per se is not considered a soft marker, and you have to correlate with all the clinical picture, and it is not an indication for the invasive test. So this is very important message which we want to give. And the second important thing, like ventriculomegaly has got some implication in the neurodevelopmental delay of newborn and the child, but not the choroid plexus. Likewise, the echogenic intracardiac foci has no implication on the cardiac function of the newborn and the children follow-up.
Yes.
So this is very, very important, which we says, and it should be remarked. Anju, what you say, it should be reported. Aditya says he doesn't. Aditya, your comment that it should be reported or it should not be reported. Because once you get report, then everybody gets confused. Aditya, your comment on it.
Ma'am, any single isolated marker, if it is of significance, should obviously always be reported. But personally, my practice is that if it is my own patient, I don't report it because I'm just giving the report to myself. If it is an external patient who's come for a scan, I just call up the obstetrician, tell them, do not worry about it, and I'm not putting it on the report.
Thank you very much, Aditya. Thank you very much.
I can add here, ma'am.
Yes, yes, Neha.
If a patient is coming you for the first time for an anomaly scan, you find an ICF. I always report it. Why? We have had cases where structurally all okay. I have had 2 such cases, only ICF, low risk, and the baby turned out to be Downs. Now the patient did not have any first trimester screen. We counseled for ward also and everything. The patient did not do anything. The only anomaly scan was done, and that too done by me with no first trimester screening. So if it is a first trimester screen done by me, or if it has been done, but I see the images, if it is really good, I don't really bother about ICF. I may omit ICF also. But when I'm seeing a patient for the first time and I see an ICF, I always report it to keep ourselves safe from medical legal point of view, because you never know which patient turns out to be Downs in spite of doing the best of anomaly scan, because an anomaly scan still has only a 70% detection rate for Down syndrome.
Thank you. Yes,
May I add something, ma'am?
Yes, sure.
Truly agree with Dr. Neha, because likewise we say with CP cyst, it should be reported. So as the screening test is offered to the patient, it may be echogenic focus or CP cyst, it should be reported. So as the treating doctor offers the aneuploidy screening, if it has not been offered in the first trimester. So I feel it should be reported. Finally, it is on the discretion of the patient. If the patient is willing to get the screening test done, it is fine. If the patient is not willing, then also it should be reported, because otherwise the whole onus is on us if we do not report the finding.
So,
Aparna,
your comment about
apologies for not being able to join earlier. So I just want to add here that I also agree with Neha and Dr. Moni here. Ma'am, this not reporting is for a situation where the patients have gone through the ideal protocol of screening through the first and the second trimester. Now, we have patients who are coming in to us directly in the second trimester. They've had no screenings altogether. And they're actually coming to us and they have this EICF altogether and for the first time. And now when I counsel them, they see that, EICF in itself is not such a big thing.
but we have to take you and understand that you've had no screening whatsoever. So please go back and get some sort of screening, and not like particularly for EICF, but you are in that bracket of quadruple. At least get a quadruple done. At least understand that you need some sort of screening. Now, if you don't report EICF also, they're all very hunky-dory. Okay, everything is fine. You're not even doing anything at all. Right? We have to have some sort of understanding that, okay, you need to screen. If you don't, so I am very clear on it. This patient needs to be screened. This patient needs to be reported. If we are in a situation where her first trimester screen was okay, or if she had her NIPT, she should, okay, fine. But you inform the obstetrician, okay, everything is fine, and this doesn't need some invasive testing. That is all. But you have to do something about it.
So thank you, Aparna. I think all panelists are agree. First of all, if we see anything, it should be reported always. Second thing, if it is a first trimester screen is negative, then we can ignore EICF. It does not need further evaluation. But if the first trimester screen was omitted, then if you see EICF, then it is the time that we do the biochemical screen. But per se, it does not warrant the invasive test. So I think all panelists, Aparna, you agree with me with all the messages?
Yes, ma'am. Yes,
so be very, very clear that if first trimester screen is not done, then it's time to do quadruple, but it is not an indication for invasive tests, which was there with the absent nasal bone or the increased nuchal fold thickness, that like it is recommended that we should go for the invasive tests. So we have to understand every soft marker. So coming to, thank you, Aparna, for being with us. We were looking for you since a long time. So Moni, it is echogenic bobble. So first of all, how you see echogenic? I want to have your comment, because many obstetrician clinicians are doing ultrasound, and how they recognize that it is an increased echogenicity, and what is the interpretation when you see the echogenicity of bowel? Moni, yours.
Echogenicity of the bowel is defined as when the echogenicity of bowel is equal to that of the bone. So whenever we are doing the ultrasound, we have to lower down the frequency, lower down the gain settings, and switch off the harmonic imaging settings, because otherwise we overestimate the echogenic bowel. Many a time this happens, they report it as grade 1 echogenic bowel when the echogenicity is less than that of the bone. So that is not significant. If the echogenicity is truly equal to that of the bone, then only we should label it as echogenic bowel. Now, as far as the causes are concerned, it can be because of any intraamniotic bleeding. The patient is giving history of any bleeding, or the patient or the fetus has swallowed that blood. Then also the echogenic bowel can be present. Apart from that, it can be associated with number of aneuploidy. Apart from trisomy 21, it can be associated with trisomy 18, 13, and various chromosomal mosaicism. Then apart from that, there are some, it is associated with chromosomal and renal abnormalities. So we have to do the targeted ultrasound as we do in any case of soft marker. The detailed ultrasound evaluation is indicated. Then it is also associated with different viral infections, the toxoplasmosis, TMV infections. There is an increased association with these viral infections. Then cystic fibrosis screening should also be offered in these cases, because this has also been associated in 0 to 13% of the cases. So I would offer amniocentesis in this case with detailed chromosomal analysis by microarray, cystic fibrosis testing, the common mutation testing. Apart from that, the viral infection, the torch PCR testing should be offered in these cases. And also this echogenic bowel is associated with the risk of IUGR later in pregnancy. So ultrasound should be offered in the 3rd trimester also to look for any evidence of IUGR. Also, it is known to be associated with different GI abnormalities like intestinal obstruction or atresia. Postnatal follow-up is also advised in such cases. So all this counseling needs to be done, and if amniocentesis per se and all the investigations turned out to be normal, we can counsel the patient that the fetus is most likely to have a normal outcome.
So thank you, Moni. So after the nuchal fold and the absent nasal bone, you think that the echogenic bowel finding needs the confirmation of diagnosis. Yes. That is invasive test. I think one message, and the second is beyond aneuploidy, the echogenic bowel can have the marker like intraamniotic bleeding, IUGR, bowel pathologies, kidney pathologies, and the thalassemia and the cystic fibrosis. So all the message to all the viewers that the echogenic bowel is an again important soft marker of aneuploidy. Secondly, it has the implication when it is present even in a euploid fetus, This fetus need a very, very close follow-up, because these babies can have the IUGR, and we should always think when you are doing microarray, then the CMV and toxoplasmosis and the parvovirus. After ventriculomegaly, this is the echogenic bowel is the thing where we should consider the diagnosis, confirmation or exclusion of diagnosis of the CMV and the toxoplasma. So, Aparna, your comment about that, do we need to follow these fetus in neonatal period, and also about the importance of echogenic bowel. Aparna, your comment.
Yes, ma'am. So we've had like lots of experience with echogenic bowel, and like I think the expert has told a lot about the various etiologies of echogenic bowel, and today only we did a twin with echogenic bowel, and one of them had actually an ascites and one of the other one had an echogenic bowel. So yes, I think infection is one of the very important reasons for echogenic bowel. And I just tell you that, you know, all of these echogenic bowels do not have a bad prognosis. You know, these infections do resolve. So I think we also have to keep our mind open that if we have done, so testing is one of the very important aspects of echogenic bowel. So when you talk to your geneticist, so aneuploidy testing is very important. The infection screening is very important. So if the test results do come out, you know, all right, aneuploidy is ruled out, infection does clear out. So I think, you know, we have to keep an open mind that we have had patients who have babies who have done well, actually, even with echogenic bowel, if you don't find a structural problem. So you have to be very careful about the bowel issues. But although there have been some of the cases where we found out some intestinal issues and, you know, all of those things where the babies did not do very well. So I think echogenic bowel is one of the soft markers, which actually is not very soft, I would say. So, you know, there are a lot of, you know, structural issues coming out later, you know, infections. So, you know, we need to be careful with those things. And we've had babies who have followed up, not done very well, intestinal obstructions. Very recently, we had a baby who was operated in the neonatal period, now doing well. So I think a lot of follow-up is required for growth, for bowel dilatation, and, you know, even a neonatal follow-up is required. So, you know, I think a lot of fetal medicine follow-up is required, and we need to keep a follow-up. Yes.
So thank you, Aparna. So one very, very clear message from our expert is that, yes, it is the panel for aneuploidy, but this is the thing where we have to keep our finger crossed. These babies require a close evaluation for IUGR, close evaluation for their neonatal behavior. And few studies said that they have a little higher chance of neonatal surgery as well. But the few studies are inconsistent, but these babies require, like, for seeing for the fetal infection, for the growth pattern, and for the intestinal issues. So this is not that soft. So Dr. Aditya, you're the short humor and the short humerus. So your comment that when you term that it is a short, and when you comment that it is a time for the invasive testing for the confirmation. Aditya, your comment on this. Aditya? Aditya, are you there?
Sorry.
Yes.
Short long bones are considered short if they're significantly short. So standard practice is to always plot the long bone lengths on a graph. And if they're significantly shorter than 5th centile or 3rd centile, only then should they be called as short. The average stature of Indian population is much less than what Caucasian population is. And all these growth charts, Hadlock, Chitties, etc. are all designed for Caucasian population. So if you plot the average femur length and humerus length on a chart, they will always be on the smaller side. So this is it. And if you do measure a short long bone, which is significantly short, it is important that the contralateral bone should always be checked. If it is an isolated unilateral short bone, it has a different implication to a isolated bilateral short rhizomalacia sort of picture.
So we really want to know that you are happy with the bilateral shortening, or you are like, what's your comment about bilateral shortening and the unilateral shortening?
Ma'am, as far as aneuploidies is concerned, the risk of aneuploidies is higher if it's a bilateral short bone because of the genetic association. With a unilateral short bone, the association with other skeletal dysplasias and other problems is much higher. So as far as aneuploidy screening is concerned, if you are calling it a soft marker, bilaterality is more important than unilaterality. But obviously, any long bone which is short should prompt an investigation into the other long bones.
So your comment about, I think we will come to Aparna as well. Aditya, your comment that one is the aneuploidy and bilateral is more indicative for the aneuploidy, and any idea about that these short bones also predict some adverse obstetrical outcome also, other anomalies or the stillbirth or the growth retardation. So Aditya first and then Aparna. Yes.
Once you, if the screening is low risk and you are looking at a short long bone, the obvious things to rule out is skeletal dysplasias and IUGR. These are the two important things. And what you need to look for is symmetrical symmetry of the growth parameters. If every growth parameter is small, it is likely that we are looking at a diseased fetus rather than a small fetus, a growth retarded fetus. If it is asymmetrical IUGR, the chances of placental pattern of placental causes of growth restriction are much higher.
Thank you, Aditya. Aparna, your comment. Usually, the obstetrician, we measure what is the day-to-day problem, femur length. And we really get 2 or 3 cases in last 3 years when the people make us so much of hangama that in routine practice, humerus is being not measured. So one thing is that scenario. And secondly, your comment about the when we see any short bone in
yes. So I would say that, you know, as an obstetrician also and otherwise as a fetal medicine person. So first of all, when we have fetal short long bones, we have to see like the gestation at which the person is coming. So you have one short long bone, you measure all long bones, right? So it is only the FL which is short or all long bones are short. So once you have a feeling that, okay, it is not just the FL, then all the long bones are short, then you will think in the lines of skeletal dysplasia. Start thinking in the lines of skeletal dysplasia. Then, of course, you have the ratios that you have to see. You have to look at the thoracic diameter. Then you have the ratios of the thoracic and the abdominal circumference and the thoracic and the biparietal diameter. And another very important ratio that we see is actually the foot length. Right? So the FL and the foot length. So in the normal circumstances, the foot length is actually the femur length should be the bigger than the foot length. So if that is smaller, then we know that there is some problem with so that's a very, very basic understanding that there is a skeletal dysplasia, right? So if it is less than 0.9, we know that there is a skeletal dysplasia. So these are some of the very basic understanding of a skeletal dysplasia. Now, if it is not just the femur length, but it is also the abdominal circumference, which is small, along with a biparietal diameter, which is smaller than the dates, right? So the first thing that happens when you have a patient with short long bones is, of course, you confirm the dates and you rule out a fetal growth restriction. And once you've ruled out a fetal growth restriction, then you confirm that all the long bones are short, and then you look out for other ratios. So once you have confirmed that, you know, all of the long bones are short and the ratios also point out towards a skeletal dysplasia, you have to have only one thing in the antenatal period. Is it lethal skeletal dysplasia? Right? Yes. Because that is what is going to determine whether you want to continue this pregnancy, you don't want to continue. One of the very important things that you know. So there are 4 common lethal dysplasias, skeletal dysplasias that we really look for. And there are various features. So are there associated, you know, thoracic compression? Are there associated fractures that you see? Is there associated hypomineralization? And are there associated features like, you know, typically, is there a telephone handle femur, or there are certain features that we look for. So this is how we actually proceed when there is skeletal dysplasia. And depending on a specific phenotype, we go forward for the genetic testing. So I know it looks a bit complicated, but when you actually do it in and day out in your daily life, it's not that complicated. But yes, skeletal dysplasia. So first is dating. Second is rule out FGR. Look for all long bones and then rule out whether it's a lethal skeletal dysplasia. Lethal skeletal dysplasia, you should terminate this pregnancy. If it is non-lethal skeletal dysplasia, nothing to be done in this pregnancy. That is the usual thing.
Thank you, Aparna. It was really wonderful that you have given really great inputs. And my question to you that it is a lethal dysplasia is one thing, and one is that what we say, because really we got a very, very like a dicey situation for our police. It is non-lethal, it is compatible with life. And when we find it, and the court also gives that why you are doing ultrasound and you missed it. So non-lethal dysplasia, your comment about with your vast experience as a fetal medicine
So, ma'am, see, in non-lethal skeletal dysplasias, I mean, see, it is all about counseling. So fetal medicine is just non-directive counseling. So we've had patients who've come with non-lethal skeletal dysplasias at 30 weeks, at 28 weeks, 30 weeks. So now it is a non-lethal situation in which the baby is going to live, right? And now we will say that, okay, now this is a situation, it has not been diagnosed, and sometimes it is an evolving condition. It may not have been diagnosed before. So we will have a postnatal evaluation. All of these things can happen de novo. There is no particular reason sometimes that this has happened, or maybe it was not seen. So we have to have a postnatal evaluation, and some things are not, and not everything can be diagnosed in utero. And we have had many patients like this, and it is not like, and we've not really had too many difficulties. Of course, I work in a government setup, so I am kind of protected that kind of a situation, but it is not difficult to counsel. Yes, of course, if you have come with a late lethal skeletal dysplasia, now with the provided MTP Act, you have the facility to even terminate these pregnancies, and we've had medical boards to terminate those. But non-lethal, we will not. We have to counsel and try not to terminate those pregnancies, of course. So I mean, of course, this is a gray area, and I would not like to comment more on it.
Thank you, Aparna.
Can I add?
Yes, please.
We follow very simple. Ma'am has highlighted majority of the points. We check this. Second, we look at the parents. Third thing is we always check the uterine artery Dopplers, because if it's high, that goes more in the favor of uteroplacental insufficiency, because these are the major causes. Then look at the structure. So major malformations will definitely be picked up, and we look at the markers of skeletal dysplasia. Skeletal dysplasia, as ma'am has already highlighted, majority of them they get picked up, but for non-lethal skeletal dysplasia, we counsel the patient. That's only. So uterine artery Dopplers should not be missed whenever you do any short long.
So thank you very much, Moni. So IOGR is very important consideration. The family's constitution is very, very important. Look for the non-lethal or the lethal, and very important message. It is from the peak institution aims that you say that we cannot diagnose everything, and we don't want to terminate non-lethal skeletal dysplasia, and we must be non-directed sympathetic counseling. This is very important, because it should not be a blame and shame game from the patient to clinician and clinician to patient, and that goes very nasty. So we have to have the clear, and we have to express our limitation for diagnosing few things, and that take help in the couple's decision making. So pylectasis, we will be very short in next 5 minutes. So Neha, pylectasis is your comment, how to follow and what are its implication? Neha,
pylectasis we measure in the axial section, and we take the AP measurements. So in the second trimester, less than 4 millimeters is considered as normal. So for my renal pylectasis between 4 to 7, we counsel the patient that in majority of the cases, in 90% of the cases, it will resolve on its own. So you need not really get worried. The second thing I would look at is the previous screening, the first trimester screening and all. If that is all fine, then I would completely reassure the patient and call back at the time of growth scan, which we usually do, and look at it again, whether if it is progressing or not progressing, and look at and also evaluate the kidney structure also along with it. When you're seeing the pylectasis, that how is the parenchyma and how is the galactasis and how is the bladder, and so you should have an idea about all these things. So if it is a mild renal pylectasis with a normal low-risk first trimester screening, then I usually counsel the patient that nothing needs to be done further. We will look at it in the third trimester.
So important message from Neha, that again the isolated pylectasis and the non-progressive pylectasis, even it is not an indication for invasive test. So Aparna, your comment that these patients who are having pylectasis and a little bit increasing the pelvic dilatation, how to follow these fetus? Baby is euploid, and you are not advocating amniocentesis or invasive procedure, but beyond aneuploidy, how to follow these fetus. Aparna, your comment.
So essentially, we generally follow the UTD classification. So generally, the earlier ones, the UTD1, normally we do one scan and we then ask them to follow at 32 weeks. So we generally don't ask them to keep following up every time and come. one key message that we should understand is that if Liker is normal, nothing is to be done.
Great. Very, very important. Yes.
And also if Liker is abnormal, then anyways nothing can be done. If it is less than 20 weeks and there is anhydramnios, please don't go running after for amnio infusion and nothing this and that and something. Less than 20 weeks anhydramnios, nothing can save the baby.
Thank you, Aparna, because it is really, we are right now having so patients. So if very important message is Liker is normal, then pyelectasis, you can be very sure that the kidney function is there. About your something issue about the urethral obstruction, which is creating the isolated, especially the unilateral pyelectasis, which is increasing on the future scan. So your comment, Aparna, about it.
If it is unilateral, then anyways nothing to be done.
Okay, so it is important that nothing to be done and baby has to be followed in neonatal period. Yes. I think that is important.
Yes. So see, if it is unilateral and the other kidney is normal and Liker is normal, so the baby will be normal.
Thank you very much for it. Your comment that we should have just after delivery, we should have an ultrasound scan of the baby and look for the urine output. Any comment?
So usually neonatologists have a protocol that if the baby has passed urine, in the neonatal period, okay, and it was a unilateral and the Liker was it was usually okay. So generally they do a scan at 4 weeks.
Yes.
Okay, so it is generally if it was suppose they are suspecting an obstruction, but if the baby has passed urine, so there is no urgency really. But if it was like a gross pelvic cell dilatation that you are suspecting with borderline oliguria, then they will do it earlier. But generally, the neonatologists have a protocol of doing an ultrasound at 4 weeks.
Thank you. The important message which I want to give to that you please communicate every finding to neonatologists, that we have to tell that this was going on and then they take the decision accordingly. So Aradhana, we will be binding up because we have a little overshooting time, around 7 or 10 minutes. So cisterna magna enlarged. Again, it is an issue. So Aradhana, your comment on it, cisterna magna.
Yes, ma'am. Thank you. So this is an important part of the genetic sonogram, and in fact, it should be measured very correctly. We can get false positive rates if we have a steep sweep angle, or if the head is a dolichocephalic shape. So the actual way of measuring is from the posterior part of the vermis to the inner part of the calvarium in the midline. The cutoff is important. That's 10 millimeters beyond 18 weeks. So above that, we call it a megasisterna magna. But then before we label it as that, we have to rule out the differentials, the important ones being Blake pouch cyst, dandy walkers, or, vermian hypoplasia. So in order to rule that out, you just have to kind of note that the cerebellum looks normal, the inferior vermis is present. There's no cystic lesion in the cisterna magna as per. So if you have this documented and it's an isolated finding, if it's an isolated finding, it's it's considered incidental and a variation of the normal. So it doesn't really increase the risk of aneuploidy. We can counsel the parents accordingly. We can follow up these babies even postnatally. The outcomes are favorable, but all of this is if it's isolated. So again, a good genetic scan, follow up with a fetal medicine expert for validation, and then in the postnatal period, you can see that if it's non-isolated, they have reported, a developmental delay in up to 11 to 29%. And if it's part of a syndrome, then the prognosis depends on the underlying condition. So these are the factors that should be noted.
So you think that if you find the enlarged cisterna magna, it should be noted and the baby should be followed about it. And it is not an indication for the, again, invasive aneuploidy testing. What's your comment, Aradhana? It is not, it is give clear message to all. Yes.
Yes, it is not an indication for invasive in an isolated condition.
Thank you very much. So we want clear message that it is not an indication if it is isolated, but yet the baby needs to have the follow-up and the neurodevelopmental delay. So Dr. Chitra Shruti, single umbilical artery, we are really, people are troubled and they are so much that this baby will not be good because anybody has frightened them. So Chitra and Shruti, your comment, if we see single umbilical artery, any extra advice we have to give or we don't give or ignore it, what to do, because we cannot change it. So Chitra and Shruti, your comment, single umbilical artery, though it is not a soft marker, but your comment on it.
A single umbilical artery, ma'am, cannot be ignored because anyways we cannot miss it because we are looking for the number of vessels in the umbilical cord in a normal level 2 scan. And when you pick up a single umbilical artery, it is an indication to do a detailed scan. Because we have to rule out CVS, it is associated with the CVS anomalies and genitourinary anomalies and GI anomalies. In fact, musculoskeletal, all systems. So once you have done this detailed scan, you have seen that there are no other problems, then you can, and you have to see whether the patient has been screened. You have to check whether the patient had any aneuploidy screening done in the past. And if the screening was low risk and you are very sure that it's isolated, then you can counsel that it has a good prognosis, but there is a risk of growth problems later on in the pregnancy. So this baby needs to be followed up. And
so Shruti, very much thank you, Chitra. I'm really sometimes get so much trouble that yes, it may be okay, but this baby needs this thing. And Shruti, just a tip that how can we make this counseling friendly? Because finally it becomes frightening. Every time the mother is having a little less, I have the single umbilical artery. So it is okay for us that yes, it is normal in certain cases. Of course, every fetus need a detailed evaluation also, but any tip for making counseling compassionate and non-frightening? So Shruti, your comment.
First of all, ma'am, many times patients think that there is some single umbilical artery means there's something with the heart or some blood vessel is missing. So that we have to tell them that there's nothing missing as such, which may have implication later on in the life, even after the baby is born. And it is not single umbilical artery per se does not mean that there's something absent in the heart. It just means that one of the artery which is only there in the fetal life is not there, and its absence does not mean if that it will have baby will have a problem. Only thing which needs to be done is a detailed proper ultrasound to see that we are not missing any structural malformation or we are not missing other markers of aneuploidy. If it is actually an isolated thing, we can reassure the patient that a lot of time we get distress calls from the obstetrician and the patient that there's a single umbilical artery. So if we are sure that is an isolated finding, nothing else to be done, there's no need for Nipt or amniocentesis. But it is very important to be sure that it is an isolated thing. So it is very important to have a detailed ultrasound. And after detailed ultrasound and after a basic aneuploidy screening, if we feel that it is an isolated finding, we can just tell patient. I usually tell patients to have a good diet and have a growth scan at around 28 to 30 weeks.
So it is actually a warning sign for us that we have to be a little careful about this baby and of course the other anomalies. But actually my thing is that the thing which cannot be changed, it is no way, but just we have to counsel it that you have to come for a more closer follow-up and for seeing the thing.
And we have to inform the pediatrician also that this baby had single umbilical artery so that they can be more careful about the evaluation of the baby after the baby is born.
So thank you. Finally, Aparna, we will wind up few questions, but it is with the all education about aneuploidy screen. Aparna, what you are finding? You are finding more and more invasive tests, or there is a reduction in final invasive tests done at your institution? Aparna, your comment. Because initially it is for reduction for invasive tests. Yes.
Yeah, so I think for soft markers, the principle that we follow is a 3-step approach for soft markers. One soft marker you find, the next step should be that you look for other soft markers. Once you look for the other soft markers, the next step that we do is that we always do a risk calculation. We do use the algorithm and we do a risk calculation, the a priori risk. The a priori risk, if you have done calculation, so if you have the patient has a double marker or a quadruple marker, we will put the risk and find the new risk. Now, if the patient does not have a priori testing done, so we take the baseline age risk as the previous risk calculation and put the new risk. Now, suppose fortunately, if the patient is the risk bracket of quadruple, we will advise a quadruple and get it done. Now, what we have, and we will calculate the new risk, and if that risk is within 1 in 250, we counsel accordingly. Now, what we have seen is that increasingly more and more patients are being referred with EICF and all of those things. So, and interestingly, without any first trimester screening. So the good part is that more and more people are coming to us with soft markers. There is increased awareness, but unfortunately without a prior screening. So in those terms, definitely we are being forced to counsel more about the available methods. But in that particular sense of the word, we are also moving towards more offering NIPT, right? So earlier from invasive, we are moving towards NIPT. So in the absolute sense of the word, the usage towards NIPT is increasing, right? So because the absolute referrals are increasing, so both invasives and NIPTs are increasing. So in a month, we do more than 100 procedures.
So thank you, Aparna. Actually, why I put this question, because the Western world is like not to reduce invasive tests. And in India, when we have a less number of tertiary care institutions, the all confusion and complexity is going towards increasing invasive tests and a more burden to the tertiary care and the fetal medicine unit. So this is the way that together, as the level of professional organization, FOXI and other thing, like all things we have to work about it, so that we have the patient friendly and the uniform protocol. So our aim is to reduce invasive procedure, especially with the false positive and they're getting more normal. So we will coming to finally a little comment from Aditya. This will be the last question. I will omit few questions. Any scoring system on low risk population versus high risk and the isolated versus cluster? So Aditya, your comment about it, and this will be the last question. Hello, Aditya, you are Aditya. Aditya, you are there?
Sorry.
Yes.
So the question is isolated or cluster?
Isolated versus cluster and low risk population versus high risk population. Is the interpretation of our all soft marker remains different? What is
Ma'am, in case of any cluster of soft markers, obviously it becomes significant. In an isolated soft marker, the chances of aneuploidies are much less. And with regards to scoring systems, yes, there are a few scoring systems. I think the first one was quoted by Prof. Nicolaides in SM-FM. And there are two other scoring systems at present in vogue. But you should follow any one of these relevant scoring systems. It doesn't really matter. Yes. The important thing is to follow a system.
And the low risk versus high risk population, like a high risk 36-year age group and the soft marker absent. Is it important? And low risk, but the soft markers are present. So how the interpretation becomes different? The same ultrasound, but the interpretation becomes different. So
ultimately, if it is a high risk population, the background risk is anyways high. So the presence of soft markers will increase an already high risk. In a low risk population, the presence of a soft marker or the absence of soft markers will further decrease a low risk. So I think at present, the consensus of opinion in US and UK is soft markers ideally should not be used to modify an already known screening risk.
Now you have ended the thing with again USA and the Western world. So Aparna, your comment that we have this discussion and we are having daily 3 or 4 patients with soft marker. So they say that don't use soft marker, but Aparna, what's your say that in developing, but in our different diverse range of obstacle setting, a soft marker has important role to play or not? So Aparna, your comment.
Like I said, ma'am, we are not an ideal population. If we are doing first trimester screening, if we are doing dual marker and NTNB, be happy, don't give importance to soft marker. But we are not doing that. We are landing up with our patients in the second trimester for the first time. So we have to look at the soft markers. And like you said, if everything is negative, then it decreases your risk of aneuploidy by almost 7 times. Right? So it's important. So that you're okay, you're good. So in a high risk patient, so suppose your background age risk is 1 in 400 and all your soft markers are negative, then your risk is cut down by 7 times, right? So that is in an ideal situation, and that gives you an idea that, okay, everything is fine. But yes, having said that, I would say that if the patient has had no previous screening and your soft markers are positive, you are forced to test further. You have to offer some other testing, and we do that in our daily practice. So you
Thank
can't.
you, Aparna. I think there is nothing ideal in this world. World is always diverse. And the second important thing, it is, of course, aneuploidy. And the second important thing, we have to document, we have to look for it. We cannot, because we can have the viral infection. We have to look for sometimes the neurodevelopmental delay or the IUGR, which is the most important cause in our setting for the bad obstetrical outcome. So soft markers is much beyond. Also, it is of course soft marker for aneuploidy, but every soft marker tells you about something extra also, and that is also important, like we can say point in making our antenatal care, like for IUGR, for the neurodevelopmental delay. So thank you very much for all the experts. So soft markers have got their own importance. I think that all audience must have a clearer idea that what every soft marker have really what to offer and what to do next, and this is very important, and when isolated versus a cluster, and which soft marker is very, very important. Another important message which we want to end, that make counseling, don't make pregnancy a frightening experience. What we said initially, if the patient is not at all interested in genetic testing or something, we have to respect their issues, because IVF pregnancy, elderly age pregnancy, they are happy with every child. So it should be, I don't say that we should not do it, but we have to be respectful to their issues, their concern. This is very important. And if we find aneuploidy screen positive, borderline, indeterminate, soft marker, isolated cluster, the thing which we have to learn, which we are not trained to learn, that how to make counseling and decision making sympathetic, friendly, comfortable, because here is the issue, that the patient is really having a lot of tension and anxiety, because we know science, but we don't know that communication skill, that what to do, and everybody want 100%. So there is nothing 100%. Every person, human being, is no ideal, nothing. I don't think that God wants us to be very, very ideal or something important, like something what we can say a perfect, because God has made world imperfect. And I still remember one very beautiful, long ago, 10 years, a foreign faculty, Australia or something, that a person with some genetic syndrome, and he says that how you dare to think that I should be terminated. So we see just few days ago, two Turners, brother and sister, very happy, very contented, very peaceful life. So what is the thing? Finally, with all the science, with all the knowledge, with all the observation, and with all the wisdom, see well, interpret well, act well, and above all, understand life, because understand life before you intervene. Thank you very much. I request everybody to join NIGF. We have a lot of things to go together. It is a really bubbling with a lot of activities. Ask your in the all 7 states that you join NIGF, and wishing you happy Navratri. And I seek everybody's blessing and support for my Foxy presidential candidature. Thank you very much. Thank you all the expert and panel for wonderful discussion. And over to Ritu for.
Yes, ma'am.
Thank you.
Thank you very much for this wonderful session, I must say. And thanks for the ocean of knowledge delivered to us. And special words of thanks for our expert, Dr. Aparna, of course, and Dr. Sadhna Gupta, ma'am. Now over to Dr. Vandana Gupta for vote of thanks. Thank you very much. It was a wonderful session.
It's been a wonderful session with a very relevant topic and a relevant clinical discussion with very clear-cut take-home messages. So I would like to thank our program directors, Dr. Sharda Jain, Dr. Ragini Agarwal, and Dr. Sangeeta Gupta. And Dr. Mandakini delivered a beautiful lecture which set the tone for the panel discussion, and the experts for the session, they gave valuable inputs, Dr. Deepika, Dr. Prerna, and Dr. Anita Kaur. And then the icing on the cake was the panel discussion, so beautifully conducted by Dr. Sadhna Gupta and carried over by all our panelists and our expert giving a beautiful comments, Dr. Aparna. So I thank everybody. I also thank the company which gave us the platform to conduct this webinar. And we would definitely like to be connected in future, all our endeavors, and wishing all the best to Dr. Sadhana for her Foxy presidential elections from all of us, and wishing everybody a happy Navratra.
Thank you.
Thank
you.
Thank you, ma'am. Ma'am, thank you so much. It was a highly informative and insightful discussion from our experts. And indeed, it's our pleasure to have all of you on this interactive session today. So thank you one and all for being very participative and on this clinically relevant topics of discussion and addressing the clinical challenges. So special thanks to Dr. Sadhana ma'am, and we wish you all the best for your winning thing for the presidentialship, and also Dr. Mauni, Dr. Shruti, Dr. Aparna, Dr. Chitra, Dr. Vandana, Dr. Ritu, Dr. Mandakini, and all the experts for squeezing your valuable time and making this platform more meaningful. Thank you so much.
Thank you.
Can say goodbye
Okay,
to all.
good
And
evening.
that's all good. Thank you, Vandana. From my part, thank you, Vandana and Ritu and all Corona team, because I'm always after them that you call them or you coordinate what is flyer logo. So I owe our gratitude to everybody for being with us all together and making this webinar highly, like I think it was thoroughly enjoyable. So thank you.
Thank
you, ma'am. Thank you, Aditya. And it is a beginning. It is not a thing. We are going to have a lot of programs, and what an expert panel it was. And really, everybody's input was so great. And hope, and we will like to have your suggestion, because you are getting referrals. So we want to have your suggestion so that we have more and more communication between the clinician and the fetal medicine expert. So thank you. So
Thank you so much, ma'am.
Thank you, Vandana ma'am, for being an excellent coordinator. Thank you.
Thank you. Thank you, everyone.
So you
Thanks
can
a lot.
end meeting, Shamanti.
Okay, good night for now.
Thank you.
Thank you, ma'am.